We are live now.
A very good evening to all the faculty members, esteemed faculty members and delegates who have joined us today for the Happy Learning Masterclass 233rd episode. This is in association with Chikkalpur, Kalburgi, Hubli, Dharwad, Mangalore and Vijayanagara societies. We welcome you to this August gathering, and the theme for today is medical legal aspects. This program is curated by none other than our program director, Dr. MC Patel, sir, who has been passionate about teaching right from the times of COVID. Let us all join hands together to evoke the blessings of Lord Almighty today. First, as inauguration. Can we have the inauguration slide, the tech team? Thank you. Now it is an honor to introduce our program director, Dr. MC Patel, sir, today. Sir has been the vice president of Foxy. He is an important medical legal consultant across India and a go-to person in case of any legal problem. He has been the president of the Ahmedabad Obituary Society, the past president of the IMA Ahmedabad, and the national president of NMO, the organizing chairperson of the Vivekanand NMO conference. Sir has been in community service and doing camps since last 33 years in the Northeast districts. We welcome you, sir, and we request you to please give your welcome address.
Thank you, Monica, for kind words. It gives me immense pleasure to welcome you all to 233 episode of Happy Learning Masterclass web series. And just mention joining society, Chikbalapur, Kalaburgi, Hubli, Dharwad, Mangalore, and Vijayanagara. I welcome Dr. M.G. Hiremat. He has kindly consented to be guest of honor to bless the webinar. He is good old friend, working with me in Foxy since years together, and he has spared time for me. Thank you for the sparing time, sir. I also welcome Dr. Kasturi Dunimat Madam. She has also kindly consented to be guest of honor to bless the webinar. I also welcome Dr. Vidya Thubi, Vice President of Foxy. She has also kindly consented to be guest of honor. I also welcome Dr. Rasli Paladi, President-elect Kasoga, and recently to be installed as a President Kasoga. She has also kindly consented to be guest of honor to bless the webinar. I also welcome all the learned chairpersons who have kindly consented to chair respective session. Dr. Prakash from Hubli, Dr. Pradeep Ganiga from Mangalore, Dr. Surekha Madam from Kopal, and they are going to chair a very interesting session about assessment of fetal well-being, and it is to be delivered by Dr. Tulsi Priya Madam from Hospet. I also welcome one more set of chairperson, Dr. Pooja Patil from Hubli, Dr. Mahananda Madam from Kalaburgi, Dr. Annapurna Madam from Kalaburgi, and they are going to chair very interesting session of MTP Act, and it is to be delivered by Dr. Pooja Margul Madam from Kalaburgi. I also welcome one more set of chairperson, Dr. Rupa Arvind Madam from Hubli, Dr. Mita Angadi from Kalaburgi, Dr. Gurkara from Hubli, and they are going to chair session uh, about POXO Act and its relevance in our OBGYN practice, and it will be delivered by me only. I also welcome two learned moderator, Dr. Bhagyasri Patil from Kalaburgi and Dr. Saviz Faizi Madam from Mangalore. They are going to moderate very interesting panel about infertility management case-based discussion. And to have their expert comments during that panel discussion, I welcome expert Dr. Ravikant from Mangalore, Dr. B.R. Barkol from Hubli, Dr. Meenakshi Devarmani Madam from Kalaburgi, and Dr. Rasmi Nayak Madam also. I also welcome all the learned panelists who are going to put their inputs during panel discussion. Dr. Madhura Madam from Kalaburgi, Dr. Silpagi Madam from Kalaburgi, Dr. Sujay from Bagalkot, Dr. Geeta Uttur from Dharwad, Dr. Vidya Madam from Hubli, Dr. Dipsi Madam from Chikbalapur, Dr. Geeta Ravikant from Mangalore, and Dr. Nishtha from Hubli, Dharwad. I also welcome my own team, Dr. Monica Umardan. She is convener in this series since long. Dr. Monica Gupta, Dr. Nivedita Datta, Dr. Satabdi, and Dr. Deepika Logani, and Dr. Megha. They are coordinator in this series since long. I put on special record help and guidance given to me by Dr. Rasri Paladi Madam, Dr. Bhagyasri, and Dr. Mita for designing this webinar and to execute this webinar also. So just mentioned by Dr. Monica, in era of COVID-19, I started this series. I invited 2-3 friends, and at that time, my intention was to meet Foxian friends on virtual ground because at that time physical meetings were not possible, and to discuss focus topic. And ultimate goal was to be helpful to our friends in their day-to-day practice. And ultimate goal was to check maternal mortality and infant mortality, because Government of India and WHO has given us a target by 2030. Maternal mortality rate should be less than 70, that is 67 or so, and infant mortality rate should be less or even less than that. Of course, there are few states in southern India, they are having this maternal mortality rate near 30. But at the same time, few are the states, particularly in northern and eastern northern area, they are having maternal mortality near 200. And it's a matter of concern for us as an obstetrician. And it is a matter of worry, of course. And if we go join hand, government, NGOs, and federation like FOXY, IMA, and our Boxian friends, particularly who are working in remote rural India, and if you go join hand, then this rate can be checked. So with this goal and to discuss focus topic and to discuss one medical legal uh, topic related to that very subject, we have started this series, and even after COVID is already over, but with love and affection of all the Foxian friends and other friends, we have continued with this series and just mention it is 233rd episode of our Happy Learning Masterclass. When I started, it was only 4 friends, and now I am happy to announce it is 8,000 plus member of Happy Learning Masterclass in this series. So without wasting much of your time, thanking you all and welcoming all the president and secretary of respective society who have joined this society and all the delegates. Thank you. Thank you very much.
Thank you so much, sir, for your welcome address. It is our now privilege to have Dr. M.G. Hiremat, sir, on the same platform that we are, and it is my privilege to introduce him as the chief guest. Sir has been the Director of General Administration and Clinical Service in Teaching Hospitals and Professor Emeritus at the KLE Institute at Hubli, the ex-principal of KLE Medical College, former Director, Karnataka Institute of Medical Sciences, ex-Medical Superintendent of KIMS, past Vice President of FOXY, ex-chairman of the Breast Committee, chief patron and founder secretary, past president of the Karnataka State OBGYN Society, also the former professor and HOD, and the head of the Excellence of Women's Healthcare at KIMS. He has been the director of Hatch IVF Center and Matoshi Women's Hospital at Vidyanagar at Hubli. Also, a former professor at Dr. Prabhakar Kore Hospital at Belgaum. Sir is also the CEO of the Arya Vedanta Scan Center. He is a recipient of the Millennium Fellow Award of Excellence in Academics, the past president of the Rotary Club of Vidyanagar, president of the Rangavaidru Cultural Association.
Thank you, madam. Thank
and-
you. I don't want to take much time.
Sure, sir. Sir, over to you for your
Yeah.
blessings, sir.
Good evening, Monica. Good evening to all. Respected Dr. MC Patel, sir, Dr. Monica, all the presidents and secretaries of five societies, learned speakers, and my colleague chairpersons. First of all, let me congratulate my senior colleague, Dr. MC Patel, for conducting more than 233 episodes of Happy Learning. Please give him a very big hand because it is not so easy to continue to do academics like this for more than 200. In fact, as rightly told by Dr. MC Patel, sir, I think COVID has given many good things. One of the good thing is that webinars started during that time and we are continuing. And not only that, we are able to learn by sitting in our house rather than going here and there trying to enter into the hall. Definitely, this has made a lot of difference. And I know that Dr. MC Patel, sir, should have been elected last year as president, but sometimes destiny is not with us, but definitely he's trying his best. I request all of you to see that Dr. MC Patel, sir, will become the head of the Foxy. Under his dynamic leadership, Foxy will grow greater. And today's the scientific program has been devised so nicely, having a wonderful these topics: fetal well-being and MTP Act, PASCO, and management of infertility. I think all the different the health issues of the woman have been covered, and we have wonderful speakers. I know them personally because they are all from my state of Karnataka. Because we all come under one banner, that is Kasoga. We meet quite often. Definitely, I will assure you, MC sir, that they will do the best, and you are one of the scientific program will be appreciated by all. I do not want to take much time. Thank you for inviting me for this program to be a part of it. Thank you, Dr. MC sir. Thank you, Dr. Monica, for giving me this opportunity. Thank you all.
Thank you, Hirematji, for sparing time. I know you are a very busy person and
Thank
engaged
you,
with
sir.
so many commitments, but even then you have spare time for me. So it is my great pleasure and thank you for the same.
Thank you, sir. Namaste.
Thank you, sir. Thank you for your encouraging words. And we all wish Dr. Patel, sir,
Yes.
all the very best. Can I now request Dr. Monica Gupta, madam, to please take over?
Thank you, Monica, and thank you, MC Patel, sir, for giving me opportunity. It's my proud privilege to introduce guest of honor for this series. First guest of honor is Dr. Kasturi V. Donimat Madam.
Donimat.
Donimat Madam. She is an ex-president of Hubli Society. She was a secretary general over there. She's a principal investigator for international research project and MCI inspector to college all over India. She's a UG and PG examiner, TOT trainer, faculty in many state, national, and international conferences. She's an active Rotarian member. Apart from academics, she's doing a lots and lots of social work also. She has conducted many CMEs, workshops, and conferences and contributed many papers and chapters into the books. Over to you, madam, for your kind blessings.
Thank you so much, Monica madam, for that kind introduction. Feel very privileged and feel feel privileged and happy to be a part of this webinar. I'm so really hats off to Dr. MC Patel sir, Honorable MC Patel sir, for conducting more than 233 webinars from COVID area. Hats off to you, sir. Really, whole Karnataka society feels very proud to be a part of your webinars. And we are looking for your leadership, and whole of our support is there for you, sir. And all the dignitaries, all the president and secretary of all the 5 societies of Karnataka, MC Patel sir, Monica, and all the guest of honors. It is really proud moment to be a part of this. And all the best for this webinar. Very nice topics have been included, like MTP Act, POXO Act, which are all sir's favorite, MC Patel sir's. Sir has done so many webinars on medical legal aspects. He has trained so many people, and he has really transferred the skill and the knowledge all over India about medical legal and other aspects, and also on infertility. So very nice topics selected and very good speakers, sir. So looking forward for a great academic extravaganza, and request everyone to support MC Patel sir. We are looking forward for your leadership, sir. Thank you for inviting me, and very happy to be a part of this.
Thank you, Kasturi Madam. You are always with me in any of my academic activity, and it is the same series in which you had been faculty also in past.
Yes, sir. Yes, sir.
So, thank you for sparing time for us.
Yes, sir. Thank you so much, sir.
Thank you, ma'am, for your kind words. Our next guest of honor is our own next Vice President, Dr. Vidya Dhobi, ma'am. She is a president-elect for 2026, and she was the president of Kasoga. She was a chairperson for Food, Drug, and Medical Surgical Equipment Committee, and she has received the Best Committee Award for that. She is a member, ICOG Governing Council member. She has received Foxy Champion Award. She is a national correspondent editor for Jogi, organizing chairperson for Kasoga 2023. She was a president and secretary for Birjapur OBGY Society. She has published various books and contributed to Foxy Focus, and she was a speaker in many of the national and international conferences and presented papers over there. And she has organized many workshops, CMEs, awareness programs. Over to you, madam, for your kind blessings.
Thank you, Dr. Monica. I'm very happy to be a part of this webinar series. Hats off to Dr. MC Patel that he has been putting so much effort, and this is 233 episode. And I must congratulate Dr. MC Patel for his connections. He's been connecting to each and every person of Karnataka. And as a vice president, he was my vice president when I stepped into the Foxy. So at every step of my Foxy activities, he has guided me from the little footstep I could achieve so much. So I'm very much grateful to Dr. MC Patel. And also, as a president of Kasoga, I must tell that he agreed to have a helpline, and we had put his name at the website as a helpline for any medical legal problems we have. He has guided us for any n number of cases free of cost. Bijapur also he visited twice, and we had a very nice moot court, as I remember in the past. So he is very well connected, very helpful, and of course, he has guided many of us. Today's webinar is a mixed bag, and definitely he always talk of medical legal MTP Act and POSCO Act so many times. And I must congratulate the Karnataka OBGYN societies. I think this is the second webinar I'm into, myself and Rajashi Palladi. Before we were there with Dr. Kazi, and all my societies are very sincere. Karnataka societies are very sincere. They were there in that webinar also at 4 o'clock. Now at 6 o'clock also, I think the attendance is full. And the credit goes to Dr. MC Patel that he has attracted so many people. He has involved so many people. As a speaker also, he has given opportunities. So I am very much thankful to Dr. MC Patel, and I am very much sure that he is going to get maximum support from all the people who have joined, not only all the people, but all the societies. Thank you very much. All the best, sir.
Thank you. Thank you, Dr. Vidya. I have seen you working since then when you were chairperson, and I was in charge of that very committee, Food, Drug, and Medical Surgical Equipment Committee of Foxy.
Yes, sir. Yes, sir.
And you are a very meticulous planner and hardworking person. So my best wishes to you also for many more achievements in Foxy.
Yes, yes, sir. Sir, you are guiding us. So thank you very
Thank
much.
Thank you. Thank you.
Thank you, Monica Umbergand also. She is also doing very great work. And also my colleague also. Thank you very much, Monica.
Thank you, madam, for your kind words. Our next guest of honor is Dr. Rajshri Paladi, madam. She's a very good academician. She's an intelligent gold medalist and doing a lots and lots of social work. She was a GSE team member representing Rotary International from India to Australia as a Rotary member. She is now president of Karnataka OBGY State OBGY Society, and she was Secretary General and Chairperson of Fetal Medicine and Genetic Committee of Kasoga. And she's a founder, director, and consultant in OBG Aditya Multi-Speciality Hospital, Kalaburgi. And she was organizing secretary of 25th Kasoga State Conference in Gulbarga in 2014. And she was a past president of Gulbarga OBGY Society. Over to you, madam, for your kind words.
Namaste. Thank you for those kind words of introduction, Dr. Monica. And it is just as Sir has coined happy learning. He's so happy to conduct the webinars, and we also feel so happy to be associated with Sir for all the webinars in all his endeavors that he has taken part. And it's so happy to know that his persistence, consistency, and tenacity to keep going in the same manner that I remember seeing Sir first when I was the secretary of Gulbarga OBG Society way back in 2010. When Sir came to Gulbarga, it was just 3 days after his father had passed away, and he had so much of commitment to the promise that he had kept with us that he came and did the CME that he had promised. And ever since then, we have been watching MC Patel sir being such a dedicated clinician, academician, and a go-to helpline. Whenever there is any medical legal issue, the only name which comes to mind instantaneously without any kind of hesitation is MC Patel sir. So, sir, thank you for being the person that you are, for the kind of guidance and for the kind of help that you keep giving us. And just as Madam said, that truly you are a helpline for many, many persons who are practicing in OBGYN, especially when there is a mob and we are in such panic. We do not know where to go and what to do. And all your series have always seen to it that there is a mixed bag to offer for all kind of issues that we deal in our day-to-day practice. And I think this learning that we get to do from the comfort of our OPD and of our clinic, and the selection of cases and the selection of topics and the selection of people, and so many have got a platform under your Happy Learning webinar series that all of us feel so connected, and we see so happily each other on this platform every time. Thank you for asking me to be here and for giving me this opportunity. Sir, we need your blessing. And thank you, Monica Umardan, for putting me and linking me up to this series. Thank you so much.
Thank you, Dr. Rasi. I do remember my first visit when you were secretary, and very recently I visited Kalaburgi. You are good host also. I do remember your hospitality extended to me during my very recent visit to Kalaburgi.
Thank you,
And
sir.
all the best when you are taking office as a president Kasoga in recently. And I am quite hopeful and quite sure that you are going to put Kasoga also to newer height, because you are also very meticulous planner and hardworking person. So all the best for new post you are going to hold next week only, I think.
Yes, sir.
And thank you for sparing time to bless us with your busy in your busy schedule also. Because when you are going to take office of Kasoga, naturally you will be busy. But even then, you have spare time for us. Thank you for the same.
Sir, we seek your blessing, sir. Being with you is a blessing for us. Thank you so much.
Yes.
Thank you,
I will
ma'am,
be
for your
there.
kind.
I will be there at Bandia.
Yes, sir.
Thank you, ma'am, for your kind words. Over to Monica.
Yeah.
For further
Thank you, Dr.
proceedings.
Monica Gupta, ma'am, for conducting the inauguration session. And we, with Sir's permission, we declare that the inauguration is now over. We would request Dr. Deepika, madam, to please carry forward with the academic session first, the first one.
So thank you so much, and good evening to everyone. And thank you, Dr. MC Patel sir and Dr. Monica Umardan for giving me this opportunity. And now with the inauguration session being over, we now begin with our first scientific session which is focusing on the topic of assessment of fetal well-being. And it is my privilege to now introduce our esteemed chairpersons for this session. So can we have the CV slide, please? So our first chairperson for the session is Dr. Prakash Biranur, sir. Sir is the president of Hubli Dharwad Obs and Gynae Society. Dr. Biranur is highly respected clinician known for his vast experience and dedication to women's healthcare. He has been actively involved in academic and organizational activities and is widely regarded for his leadership and contribution to obstetrics and gynecology in the region. So we welcome you, sir, as our chairperson. So can we move on?
Yeah, thank you.
Our second chairperson for the session is Dr. Pradeep Ganiga, sir. Sir is the past president of Mangalore Obs and Gynae Society. Sir is the professor and head of Department Obs and Gynae at AJ Institute of Medical Sciences, Mangalore, and is currently the national coordinator of the Endometriosis Committee of FOXI. Sir is well known for his academic excellence and contributions to teaching, research, and clinical practice. We welcome you, Dr. Pradeep, sir.
Yeah, thank you, ma'am. Thank you.
Can we have the next CV, please? Yeah. Our third chairperson is Madam Dr. Surekha SM, who's the associate professor and in charge head of department at Kopal Institute of Medical Sciences, Kopal, with over 15 years of teaching experience. She is a postgraduate guide and has received several state awards, including recognition for conducting a highest number of deliveries in HIV positive women. That's a great achievement, ma'am. Ma'am has also served as Lakshya coordinator at national level and is actively involved in multiple research projects and is faculty at several state and national conferences. So, ma'am, we welcome you as our chairperson. And could I request our one of our chairpersons to please introduce our speaker, who is Dr. Tulsi Priya. So can we have Dr. Tulsi Priya's slide, which is there? So can we ask our chairpersons to introduce Madam? Dr. Prakash, sir?
Yeah.
Any chairperson can take.
Yeah, Dr. Prakash, sir, can you introduce Madam?
Yeah, and we have a Dr. Tulsi Priya. She's a consultant obstetric and gynecologist. She's having experience of 11 years in private practice at Sharanam Hospital, and she's participated in Kasoga conferences as a panelist and active member of Vijayanagara Obstetric and Gynecology Society. She's a life member of FOXI and director Sharanam Hospital, Hospate. And her areas of interest are high risk pregnancy, infertility, and fetal medicine. Over to you, ma'am.
Thank you so much, sir. So good evening, one and all. At the outset, I want to thank MC Patel, sir, Hiramat, sir, and our incoming president, Dr. Rajeshri, madam, and my own Vijayanagara OB Society of Karnataka for giving this opportunity to present a topic in front of you all. And I feel privileged to present this in front of my teachers also where I graduated, that is MRMC Gulbarga. I feel very much, I feel a student in front of my teachers, though it's been so many years. So I shall share my screen.
Bizarre. लीव करे तो फिर ज्वाइन कर सकते.
So is my screen visible?
No, ma'am. On friends, Samir ji, can you help her? Can you just guide Madam? Ma'am, what is the problem that you're facing?
Ma'am, actually, after giving a share option here, I'm not getting the document here.
So your document opened somewhere that you can see it on the screen?
Yes, ma'am. Yes, ma'am. 1 second.
Ma'am, just double click that. Yes,
Now,
ma'am.
Yes.
It has started. Ma'am, just, yes, ma'am. It is visible.
Okay.
Now please go on to full screen.
Yes, ma'am. Now it's seen, ma'am?
Yes, ma'am. Perfect.
Okay, ma'am. Okay. So, my topic, what I selected today is almost the basic and it's very fundamental topic for each and every obstetrician in their in their practice. That is antenatal assessment of the fetal well-being. So, assessment of fetal. What is mainly assessment of the fetal well-being is assessing the fetus before the onset of labor to prevent the intrauterine hypoxia or antepartum hypoxia and intrauterine fetal death. So we have the pre-existing, whom should we offer this assessment or whom should we offer this intrapartum antenatal fetal monitoring? All the pregnancies who pose an increased risk of antepartum fetal hypoxia are candidates for the fetal monitoring. So it may be like the pre-existing maternal conditions or pregnancy-related complications. When we detect, we can do timely delivery and prevent the intrauterine fetal death and decrease the perinatal morbidity and mortality. So the common conditions, the few conditions which I have mentioned here when it comes to the fetal, is when there is fetal distress or decreased fetal movement or fetal growth restriction or monochorionic multiple gestation and oligohydramnios. Maternal and fetal, it is placental abruption, is aluminization, it's postpartum pregnancy, gestational hypertension or preeclampsia, gestational diabetes, and there is any history of the fetal death prior pregnancies. And in maternal conditions, when there is advanced maternal age, that is when the mother is more than 40 years old, a cyanotic heart disease if the mother is suffering, hypertension and chronic hypertension, morbid obesity, chronic renal disease, SLE, and hyperthyroidism. So it can be divided into three components. One is clinical monitoring, one is biophysical monitoring, and one is biochemical monitoring. So clinical monitoring is the parameters which we look into physical parameters, that is the maternal weight gain. So in the second trimester, the average weight gain, like we have like 1 kg per fortnight or excessive. If the mother is gaining excessive weight gain in the second trimester of the pregnancy, that is a fine sign of the preeclampsia. If the mother is not gaining any weight, then it may suggest the IUGR. So assessment of the symphysis fundal height, then blood pressure and the evaluation of the fetal edema. The biophysical monitoring is the mainstay of the treatment, which includes the antepartum test and the intrapartum test. So the antepartum test, which includes fetal movement monitoring, non-stress test, that is NST, contraction stress test, biophysical profile, and modified biophysical profile and Doppler USG. Intrapartum includes continuous electronic fetal monitoring, that is used with the help of machine CTG. It's called cardiotocography and fetal scalp blood sampling. So what is the main basic funda of this test, doing this test? Is mainly we have to detect the intrapartum fetal hypoxia, whether the fetus is exposed for the hypoxic conditions, which can lead to metabolic acidosis, then CNS depressions, and changes in fetal biophysical activity and causing further to very catastrophic condition, that is intrauterine death, to prevent maternal mortality and morbidity. First is the fetal movement monitoring that we called fetal movement count. So this is very simplest method and is very inexpensive also, which we can explain to the patients in our own language in the patient convenience. So it's performed daily from 28 weeks. The most common technique what we use in fetal movement monitoring, it is Cardiff count of 10 formula and daily fetal movement count. So Cardiff count of 10 formula is like we ask the patient to count the fetal movements in any time of the day. If the patient is perceiving 10 movements then the count is stopped, but it should be within a span of within 12 hours. If the patient is not perceiving 10 fetal movements within the 12 hours, she has to report to the nearby, their obstetrician or nearby consultant. So this is the easiest method most of them will follow. One is the daily fetal movement count. We divide in these movements like count into morning, afternoon, and the night. So we are going to take 1 hour between the morning, 1 hour in the afternoon, and 1 hour in the night. We ask the patient to perceive the fetal movement. In that 1 hour, at least she has to perceive the fetal movement, one movement.
ಶನಿವಾರ ಭಾನುವಾರ 2 ದಿನ ರಜಾನಾ ಅಥವಾ 18 19?
So we ask the patient to perceive the movement, one moment. So if she perceives all the movements in morning, afternoon, and night, and it should be multiplied into 4. So if she perceives more than 10 movements within 12 hours, it is normal. If she doesn't, then she has to report to the outpatient department. So then coming to but the fetal movement count is like, it's like used as a screening test. So with the backup of the other tools also, like using NST or biophysical profile when she doesn't pursue fetal movements. But one drawback is that sometimes these movements cannot predict in if there is any abruption, this test is cannot be used in this does not detect the does not detect it, one drawback of the fetal movement test. So one next is a non-stress test, which everyone are aware of it, which every obstetrician and labor room has the NST. So based on the hypothesis is that the heart rate of a of a fetus. So fetus will respond to a movement or a spontaneous induced movement in the process of acceleration in response to fetal movements. Testing is started, ideally testing is started after 32 weeks of the pregnancy. But if there is previous any stillbirth in their previous history, obstetric history, we recommend 1 or 2 weeks earlier only for doing the NST, and we should repeat it twice weekly. So there is the simultaneous recording of fetal heart rate as well as the uterine activity. So it is very simple to perform. It's relatively quick as well as it is non-invasive. It is valuable to identify fetal well-being than illness. So interpretation, we are going to interpret NST as reactive, non-reactive, or inadequate. So reactive is like when the heart rate of the fetus is 110 to 160 beats per minute. It is normal beat to beat variability is 5 beats per minute. It's if the NST is having 2 accelerations of at least 15 beats per minute above the baseline, each lasting for 15 seconds within the span of 20 minutes period. Then we are going to call it as a reactive NST with no decelerations. And non-reactive test is like when there's a criteria are not met, then we are going to call it as non-reactive. It can be repeated on the same day, when the mother, she hasn't taken her food, or when she is hypoglycemic, we will ask her to have some liquids or then we can repeat the test in the same day or the other day. So the other test is also called, there is one more option is inadequate. Then we use this vibroacoustic stimulation to read a NST. So evidence shows that the risk of fetal demise within the week, like when we do a NST, the risk is only 3 in 1,000 with well-responding, well-oxygenated fetuses. But when it is NST is non-reactive, the perinatal death goes up to 40 per 1,000 live births. So this is like, everyone would have seen this NST. Everyone will have their CTG machines in their label rooms, and this is the reactive NST. And this is non-reactive NST, where we've seen that the fetal baseline variability, beat variability is not there, and this is in non-reactive NST. So next is what we call as contraction stress test. This is records fetal heart rate in response to uterine contractions. So we use IV oxytocin for IV oxytocin, or like go for nipple stimulation. So this test is like very challenging. So we no more use this test because the NST and CTG has taken over the CST test. So like we have next is biophysical profile and modified biophysical profile. So we are combining this biophysical profile has these parameters we consider in the biophysical profile. One is and the score is given to each parameter. If the score is given 2, if it is if the criteria are met. If the criteria are not met, the score is given as 0. So NST, if it is reactive, the score is 2. Fetal breathing movements, if it is more than 1 episode lasting for more than 30 seconds, we have give a score of 2. And gross body movements, it is more than 3 discrete body or limb movements, the score is given as 2. And the fetal muscle tone, if there is more than 1 episode of extension with return of flexion, then it is given as 2. Amniotic fluid, that is more than 1 pocket measuring 2 centimeter in perpendicular planes, that is given as 2. So the total score comes up to the 8, 10, the biophysical profile. The BPP, yeah. This is how like we interpret the score is normal. If the score is 10 by 10, it's normal, no intervention is needed. 8 by 8 is also considered normal, then no intervention is needed. If the score is like 6 by 8, then there is equivocal. There is a possibility conditions of hypoxic. The fetus is exposed to the hypoxic conditions. If the fetus is mature, we can repeat it and we can deliver. If the score is 4 by 8 or less than 4, it indicates there is high suspicion of asphyxia. When we combine with CTG, then it's an management like we need to deliver immediately. So all components are not equally predictive, but when it comes to the high-risk patients, we have to do weekly screening, and use of the steroids can change results also. So coming to the ultrasound Doppler, the most extensive method where we use in and out now, which has changed the treatment and management of the fetuses before what we used to be now. Each and the Doppler has helped us so much in detecting the fetal hypoxia so quickly and act very swiftly and preventing the perinatal mortality and morbidity. In Doppler, usually we consider when it comes to the placenta fetus, we consider the umbilical artery and the middle cerebral artery of the fetus component. And with the mother component, maternal component, we consider the uterine artery. So umbilical artery is represents the placental vascular resistance, should be regarded as the indicator of the resistance in the placenta vascular bed. So it increases in the end diastolic flow that is seen with advancing gestation is a direct result of increase in the number of tertiary stem villi that takes place with placental maturation. Disease that obliterate, So disease that obliterates small muscular arteries in the placenta tertiary system will result in a progressive decrease in end diastolic flow in the umbilical artery Doppler waveform until absent and reversal is noted. So when we see that there is a reversal of diastolic flow in the umbilical artery, then it is the patient is already in danger. It is already exposed into intrauterine hypoxia, which we see commonly in IUGR and severe oligohydramnios. So it is like we need to deliver immediately. So these are the normal forms of umbilical artery Doppler. This is the normal wave, and this is the reduced end diastolic velocity. This is the absent end diastolic, and this is the reverse end diastolic waveform. Then comes to the middle cerebral artery. It is the most accessible cerebral vessel to ultrasound imaging in the fetus. It carries more than 50% of the cerebral blood flow. In the presence of fetal hypoxemia, there is central redistribution of blood flow occurs, which there is an increased blood flow to the brain, heart, and adrenals, and a reduction in the peripheral and placental circulation. This redistribution, we all know that it is called as a brain-sparing effects and play a fetal adaptation to oxygen deprivation. So after 34 weeks, physiological redistribution may occur owing to changes in the flow in the heart, leading to relatively deoxygenated blood being shunted to the cerebral artery. In hypoxia, there is progressive reduction in resistance in the middle cerebral artery. So in cases of chronic fetal hypoxia, the blood flow in the fetal circulation is distributed. So then there is vasodilation of middle cerebral arteries, which correspond, there is increase in diastolic flow and there is hyperperfusion is then considering hyperperfusion is considered pathologic. If hypoxia persists, the flow will return to normal level. This reflects that a terminal decomposition is already occurring in the process of the fetus is already in acidemia and in or brain edema, it is suffering. So this is the MCA Doppler wave. Coming to the uterine artery, this is like uterine artery. Nowadays, it is used as the screening test combined with biochemical parameters in first trimester of the pregnancy as well as the second trimester of the pregnancy. So it is it has a like what are the abnormalities when we see in the uterine artery flow? When there is a high mean resistance that is more than 95th percentile of RI and PI, and there is unilateral uterine artery notch and bilateral uterine artery notches are noted. So we act and we prevent it so the fetus shouldn't be exposed to hypoxic conditions in further pregnancy. So uterine artery notches are present in almost all women at conception and early pregnancy, and they should disappear by 24 weeks. So so this is about the Doppler. Now this is CTG, cardiotocography, which we use in our labor ward. So this is like, basic, this is like must machine that we needed in delivering the normal fetuses. And to deliver increase the vaginal deliveries rather than C-sections with the help of the CTG, we can do that. So CTG is a technical method for recording the fetal heartbeat using ultrasound, uterine contractions during pregnancy, typically in the third trimester. So at the timing of the CTG, so antepartum and on admission to the labor room, which is called labor room admission CTG, it's recorded for the duration of 20 minutes. So, and it should be done after the 32 weeks of the pregnancy, CTG. So the purpose of CTG is to identify about the fetal well-being and if there are any interventions to be carried out, if we detect any abnormal patterns of the fetus recorded in CTG. So mainly the baseline fetal, the CTG consists of the baseline fetal FHR, variability, accelerations, and decelerations. So the well-oxygenated fetus demonstrate a stable baseline with good beat-to-beat variability. So this is example of the reactive reassuring CTG. So even what happens when there is fetus is exposed or is response to hypoxia? One is like fetal heart rate variability may be retained or it may increase. Then the fetus is in compensated state, but there is normal cortical function, there is proper cerebral oxygenation, and it can last up to 60 minutes. If the fetal heart rate variability is not maintained, if there are decelerations, then the fetus in a decompensated state means there is a decrease in cerebral oxidation, eventually leading to the cellular damage. A normal antenatal CTG, you can see here. So features of a CTG, baseline rate It's for baseline heart rate, baseline variability, accelerations, decelerations, response to stimuli. So we have the classified further into CTGs are classified again. How to interpret CTG? Like it is classified into reassuring, non-reassuring, and abnormal. So this is a table given about what is reassuring CTG, non-reassuring CTG, and abnormal CTG. So reassuring CTG is like when the baseline heart rate is 110 to 160 and baseline variability is 5 to 25 beats per minute and decelerations there are none. When all the three features are reassuring, then it is a normal CTG. When non-reassuring is like one of the non-reassuring feature, one non-reassuring feature and two reassuring features is suspicious of CTG. Abnormal CTG is like one abnormal or two non-reassuring features, then we can say it is abnormal CTG. So RCOG classification of CTG, all the three normal CTG, all three features are reassuring, suspicious CTG, one non-reassuring and two reassuring, pathological, one abnormal and two non-reassuring CTGs. So again, it's the same thing. It's about three types of interpretation, reassuring, non-reassuring and abnormal CTG. So accelerations must be more than 15 beats per minute and more than 15 seconds above the baseline. Should be more than 2 within the span of 15 minutes period. Always reassuring when present, may not occur when fetus is sleeping. Should occur in response to fetal movements or fetal stimulation. Non-reactive periods usually do not exceed 45 minutes. So more than 90 minutes and no acceleration, then it's a worrying situation. So deceleration, again, it's classified into early deceleration, late decelerations, and variable decelerations. So early decelerations we usually see in head compression, and late decelerations is like the fetus is almost, there is an intragrowth uterine restriction and there's a fetal hypoxia of 50%. The baby is exposed to fetal hypoxia. And variable decelerations we usually see in uterine rupture, cord prolapse, we see in variable decelerations. So these are the types of the variable deceleration, that is biphasic or W shape, which are lasting more than 60 seconds, failure to return to baseline, and no shouldering is there, reduced variability within the deceleration. So this is one of the pattern. This is the W shaped or the variable deceleration, that is biphasic or W shaped, which is lasting more than 60 seconds. So this is the normal non-reassuring CTG. So again, there is a table of this. So finally, before this, we have to remember this big picture of interpreting the CTG, the mothers, that is M for meconium, O for oxytocin, T for temperature, H for hyperstimulation or hemorrhage, E for epidural or rate of progress and risk factors, S is scar rupture. And we have few more tests like fetal blood sampling, fetal lactate, fetal scalp lactate, fetal echo, and fetal pulse oximetry. And at the last, I want to tell all, because this is when you give a mother emotional support, a moral support from the family, the fetus is always happy. And including that, she needs an emotional love and care from the family too.
The pregnancy tests, because unmarried young.
Thank you so much.
Hello.
Yes, sir.
Can you hear me?
Yes, sir.
Yeah, thank you.
Yes,
Thank
sir.
you, Dr. Tulsi Priya, madam, making it a very crystal clear about the fetal monitoring. Thank you on behalf of webinar organizing team.
Sir, thank you so much, sir.
Yeah, sure. Nice.
Can I request
I
the
think
chairperson, Dr. Surekha madam, or if you're there, please. Or Dr. Prakash sir.
Yeah, it's
Yes, madam.
very well explained by Dr. Tulsi Priya, and it was the all charts were very good, and it's very informative. Okay, thank you.
Thank you, sir. Thank you.
Very nice
Surekha ma'am.
presentation, my Dr. Tulsi. She is my childhood friend, and I'm very thankful to chair this session because I'm sharing this session with Pradeep sir. Sir is my undergraduate teacher. Thank you so much, sir. Thank you, Tulsi. It was a nice presentation.
Thank you. Thank you.
Yeah.
Thank you.
Nice, Dr. Surekha. Thank you.
Thank you, sir.
Remembering me. She was our undergraduate in Aging of Medical Science, Mangalore.
Yes, sir. Yes,
Thank you,
sir.
Surekha.
Thank you, sir.
Yeah, sure.
Thank you, everyone. And thank you, Dr. Tulsi, for a crystal clear and an informative talk on antenatal fetal assessment. Let us move ahead with the next academic talk, which is on MTP Act. The tech team, can you please share the slides? The second session, the talk will be taken by Dr. Pooja Margal Madam on the MTP Act, and our chairpersons are Dr. Pooja Patil, Dr. Mahananda, and Dr. Annapurna Madam. Can we request the tech team to please share the slides of the chairpersons? Please share the slides of the chairpersons, please, not this one. Dr. Pooja, slide, please. Dr. Pooja Madam is a consultant OBGY at the KV Patil Maternity Hospital and Nursing Home at Hubli. She's currently the secretary of the Hubli Dharwad OBGY Society. She has a very strong focus on high-risk pregnancy management in her clinical practice, and she has attended various national and international conferences. We welcome you, ma'am, as a chairperson for this session. The next slide, please. Dr. Mahananda Madam is the professor in the Department of MRMC Kalaburgi. She has served as a medical superintendent for 5 years. And she has various positions held as the past president of the GOGS and the vice president of the society. She has been very actively involved in various public health activities. We welcome you, ma'am.
ಸೋಮವಾರದೆಲ್ಲ ತಗೊಂಡಿದ್ದೀನಿ ಅವರು ಪ್ರಕಾಶ್ ಸರ್ ಮಾತಾಡಿ ಅವ್ರು ಹೇಳ್ಬೇಕು ನಾವು
Teaching professor since the last 30 years. She's the undergraduate and postgraduate examiner, and she's currently the professor at MIMS Vikramabad and presently the president of the Gulbarga OBGYN Society. We welcome you, ma'am, and we request our chairpersons to please introduce our speaker for today. Annapurna, madam, please unmute yourself.
Yeah, I've done it.
Yeah, thank you.
I've done it. Yeah.
Can
So,
I
Dr.
introduce, madam?
Hello.
Okay.
Any
Hello.
ma'am.
Who's going to do it?
Hello. Yeah. Can I do?
Yeah.
Yes, Dr. Mananda, ma'am.
Yeah. Pooja Margol is my student in MRMC. She is associate professor of OBG in Kalburgi and consultant at PS Margol Hospital, Kalburgi. Master Trainer for Comprehensive Abortion Care, Kalburgi. Master Trainer of AMC, Kalburgi. Thank you, ma'am.
Hello, everyone. Am I audible?
Yes.
Yes, ma'am.
Yeah. Thank you, everyone. It's an immense pleasure for considering me to give a talk over the MTP Act and rules in a forum where I say it is a happy learning, a learning which is really genuinely considered as happy. Dr. C. Patel once, and I was really
happy to know that your knowledge about that, the rules, the way you handled the situations and all which you have told in a talk there. And I would really thank you, our Dr. Rajeshri Paladi ma'am. Just taking her name gives a confidence. So she's considered as a confidence giver, like horses like us who can jump and hack. Thank you, Bhageshri ma'am, my senior, my mentor. She always gave confidence to me. Thank you, Annapurna ma'am and Amanda ma'am. Today's topic is MTP Act and rules. So I'll be considering the salient features about the MTP Act and its amendments in 2021, MTP rules and its amendments in 2021. Now, why Act and rules? Act, as I say, it is a primary legislation, like what the government gives it. And the rules are the one which we execute in a way like what all can be taken so that the act is considered. Like, for example, forms, documents, and how to go on with that acts and rules so that we do not breach the law. Know about the revised documentation forms, information and all other related laws, like sister of the MTP Act being the PCPNDT Act, a POXO forms a part of it. So as a doctor, I don't know much about other rules and acts, but these three for a gynecologist, that is MTP Act and rules, the POXO Act and the PCPNDT Act, which appear as if they are sisters and brothers, has to be like we have to eat and drink about those things. So there was a speech on this topic in front of lawyers and judges in Gulbarga, and they said, yes, this confidence is needed from doctors when you speak about the case, because we are the one who will be handling if something goes wrong. So what is that MTP Act? What are the changes which has happened in 2021? It is nothing much. The upper gestational limit, which was considered to be 20 weeks, and after 20 weeks, which was 20 to 24 weeks, was considered as special categories. Now it is 20 to 24 weeks, which are considered as special categories. A boon for the patients, a boon for the doctors. Pregnancy termination, anytime during the pregnancy, if there is a substantial fetal abnormalities, but we have to consider the rules, we have to consider the execution procedures correctly. Failure of contraception, if you take, the conditions extended also to the unmarried women. Yes, while handling the unmarried women, it is very difficult to consider, yes, whether the rule or the act stops here. Unmarried women are considered as safe, but unmarried, sir, whether the slides are visible?
Yes.
Yes.
Hello?
Yes, they're visible, Pooja. Go ahead.
Slides are visible, madam?
Yeah, yeah. Go ahead.
Yeah.
So it is extended to the unmarried women, but with very much consideration we have to be there. Opinion of one RMP for MTP up to 20 weeks. Previously it was up to 12 weeks, and 12 to 20 weeks, two RMPs have to give the opinion. And now it is up to 20 weeks and one RMP can give the opinion about the MTP to be considered, and two RMPs after 20 to 24 weeks. Next being the confidentiality to be strictly maintained, whose consent has to taken, because after this I'll be sharing what are the different forms like consent form, RMP opinion form. In the consent form, it is the consent of the patient, I mean the person who comes to you, that is patient itself. It is not a husband or a relative, because it is considered as consent, that is confidentiality. She may say, please do not disclose it. But whenever any rules and acts are there, yes, there are different breaches, there are different considerations, different things we have to think of. Like, yes, if we take a women's consent and later something goes wrong, those all will be discussed in the next slides. Then comes indications. As I utter the words indications, then I'll be using another word called as categories. Now, conditions or indications are the similar, which were up to the 12 weeks or 20 weeks, like up to 12 weeks, like save the life of a person, I mean, women. If she has any grave injuries for the physical or the mental health, the child being born will be a physically handicapped or a mentally abnormal, a pregnancy caused by a rape or incest, pregnancy which will be caused due to a failure of contraception. These all were the simple indications. Sex selection is not an indication for pregnancy termination under the law. I have highlighted it as if we are both in front of a court that I'm not doing it. So sex selection, yes, it is not a part. Next word, this is categories. Indication that comes to categories. MTP between 20 to 24 weeks will be considered as categories, not an indication. So survivors of sexual assault or rape or incest will come under this 20 to 24 weeks. Minors, change of the marital status during that procedure. If, for example, she's divorced or she is a widow, so during that time, if these things happen, then she may be considered in special category. Women with the physical disabilities, it falls under Disability Act 2016. Mentally ill women, including mentally retarded person. Now the question comes whether she should be completely mentally retarded, then she comes under the categories. It has been said that if she's on medications and she shows the medications, it can be considered as some mentally ill woman. Fetal malformation, which has got a substantial risk, yes, the child, if born, will have a physical or a mental abnormality or seriously handicapped. Women with the pregnancy in a humanitarian setting, but whatever the disasters or whatever the emergency situation, they should be declared by the government, not the local disasters. Who can terminate a pregnancy? We all know it's a registered medical practitioners who possesses the medical qualification, entered in the state medical register, has got an MTP training. What is it? She can be a postgraduate, 6 months house surgeonship, 1 year of experience in any of the obstetric and gynecological hospital who has the facility of MTP, and an RMP who has taken a training from a government setup, who has like taken 25 cases of MTP observed, 5 cases performed independently, then she can be considered as an experienced in a MTP. For MMA, those like MBBS student who has completed her MBBS, she can consider as an MMA provider. Like she had at least 3 months of experience in an obstetric and gynecological hospital, or independently performed 10 cases of giving an MMA in a training institute and provided with a certificate of MMA provider. Then comes the consent. Who should give the consent? It is the consent of a woman more than 18 years. She can be married or an unmarried. It is okay. But in case of a minor less than 18 years or a mentally subnormal person, consent is given by a guardian. When we talk about act and rules, no words are considered as words. If I say guardian, the guardian has been defined in the amendments in the act and rules. That is, a guardian is a person who is legally responsible for the lady. So any person coming as a guardian is not considered as a guardian. He or she should be a legally responsible person. Opinion of an RMP, that is a registered medical practitioner. This is a form which has to be filled before, it is considered as we're considering the procedure, or minimum of 4 hours within the procedure what we are doing. So for termination of a pregnancy up to 20 weeks, opinion of 1 RMP is required. But for the termination of the pregnancy beyond 20 till 24 weeks, opinion of 2 RMPs are required. Now, what about after 24 weeks? Yes, this will be considered again, where we consider the word called as medical board. Sites for pregnancy termination, where all we can do. Your government setup, not to ask. Yes, private sector. Private sector, it is a district level committee is constituted by the government to give the approval of that site for the MTPs. It can be like if you take an first trimester abortion or a second trimester abortion, different methods are there. If it is a MMA, like giving a medical methods of abortion, the person giving will be an RMP. She or he can give in an OPD, but yes, she has to have an established linkage to the approved site. For example, she closes her OPD by 4, what happens later? So she has to have an established link to an approved site with a certificate of that certificate, which should be attached in the OPD clinic. MTP site approval, if you ask what to do or how to get it. Public sectors do not need. But private sectors needs an approval before starting an abortion procedures. And it is granted by district level committee, which comprises of 5 members. The DHO will be the chairperson or the chief medical officer will be the chief person. One member shall be a gynecologist, a surgeon, or an anesthetist. And one member should be from a local medical profession or an NGO. But at least one member of that committee should be a woman. The tenure of these people being 2 years, but an NGO person is for 4 years. That is 2 terms. Now, this district level committee, once we submit a Form A, there is one thing which was called as e-Kalyani in Karnataka. It's a portal where we have to send our report in the form of a Form A, but since still it is not under work, we can hand over our forms to the DLC committee. This is applied in the form of a Form A. The site inspection will be done. If they are satisfied, they will approve and give us a form which is called as a Form B. And if it is not satisfied, they will give us the deficiency reported about that site. And if the site is re-inspected, and later the certificate is issued as Form B. So Form B, this is a Form A. Like up to what weeks you are considering, to 12 weeks or 12 up to 24 weeks, category A or a category B. So we have to mention about the name of the place, the address. It's a non-government procedure, which state it is. If it is a category A, as I was telling you, example, up to 12 weeks only if we are considering a gynecological examination table, registration kit, sterilization equipment, basic things about emergencies and facilities of transport. But yes, if it is a category B between up to 20 to 24 weeks also, an operating table and associated instruments, anesthetic equipment, resuscitation equipment, everything is needed. Form B, this is the form of the certificate what they provide, that this site is considered for the is approved for the MTPs to be considered in their hospital. So as I said you, these are the infrastructures for the either category A, this is B. If it is to be considered beyond 24 weeks. Beyond 24 weeks, operation table, instruments related to abdominal or gynecological surgery, anesthetic equipment, resuscitation, sterilization, drugs and parenteral fluids for emergency use, backup facilities for the treatment of shock, facilities for transportation, ultrasound guidance, blood for emergency. Hence, these all are necessary for the 24 weeks. Only after a medical board has given a consent for the termination. So what is medical board? Pregnancy termination for a substantial congenital malformation. Where I said is there is no gestational limit. If there is a substantial congenital malformation and she wants to terminate it, she has to go and approach a medical board. Where to approach a medical board? It is a government medical college. JIMS has got a medical board which is headed by Dr. Usha Dodmani Madam, HOD JIMS Kalburgi. Members of this medical board will be a gynecologist, a pediatrician, a radiologist. Others, as it will be like, for example, we are considered a particular type of congenital anomaly. We want a specialized person in that type of specialization, then other member can also be considered. And the medical board has the power to either allow or deny. Now, what all they will be considering? The first thing to consider will be the safety of that woman. Whether the procedure would be safe at that gestational age. The next comes whether that fetal malformation has really got a substantial risk, that whether it will be incompatible with the life of a child born, or whether it will be completely physically or mentally abnormal or seriously handicapped. And then they will co-opt with other specialists in the board. They will send additional investigations if required, and then decide whether to terminate or to continue with the pregnancy. So the functions of the medical boards are to examine the women and her reports, whether she can approach for the medical termination, provide the opinion of medical board in the form of a Form D. Now this Form D will either will give the consent or they may reject. And once the consent has been given in the form of a Form D, it has to be initiated within 3 days. The medical board has to start initiating the procedure within 3 days of the request issued. Now, to ensure that the termination procedure, medical board will have all the things whatever I have told you, and then once it gives the consent, yes, the pregnancy can be terminated. The procedure has to be begun within 5 days of the receipt of the request of medical termination. This is the Form D. They write about the name of the person, age, registration number in that hospital, what are the available reports to be reported, and extra additional investigations if they are needed, they have to be performed. After examining all these reports, they have to come under the opinion whether the medical board gives the permission for termination or denied. Yes, if they allow it, whether physical fitness of the women is considered for the termination of the pregnancy. Yes, she is fit enough to undergo the second trimester termination. And it has to be duly signed by the persons who are in the medical board. And that has to be handed over to the labor room or to the hospital where she is the termination of the pregnancy. So these are the mandatory documents because it is not easy to remember C, D, I, E, all those things. So C was a consent form, has to be signed by the lady. Form 1 and Form E, it's an opinion form. 1 is up to 20 weeks. If we are considering an RMP opinion after that, that is 20 to 24 weeks, it is Form E. Then comes a Form 2. Form 2 is a monthly handover register. That is, we have a monthly statement, we send it to the DHO office. That is head of the hospital or the owner of that place has to send the monthly statement. Form 3, that's an admission register which we have to maintain, kept for a period of 5 years from the last entry. Form D, which was an opinion given by the medical board. And these documentations accordingly for the medical or the surgical methods both have to be filled. So for example, if it is a MMA which has to be considered, Form C, yes. Form 1, yes. Form 2, yes. Form 3, yes. Form D is only after 24 weeks. Form E is from 20 to 24 weeks. So this is a consent form. If you would have seen, the first will be about the patient. But yes, if she is a mentally subnormal or a minor lady, it is by the guardian. And this is about the RMP opinion form, where the opinion by me, for example, I am considered as a registered medical practitioner who is considering the termination. I have to give the address of me and the women's full name. And next comes the what was the indication. This is the indication, as I told you. What was the indication has to be ticked and twice signed. One is giving the record of me and the patient, that is a doctor who is performing and the patient. The second being why is the MTP considered or what is the indication. The next form being the Form E, which is MTP Act beyond 20 weeks, but only up to 24 weeks, where 2 registered medical practitioners' names are there with their full address. And then what was the category? It is not the indication, it is the category, again signed by both the persons. If you see the note down, account may be taken of the pregnant women's actual or reasonable, foreseeable commitment on determining all those things. This sentence was again and again spoken when I was giving the same speech in front of the judges and the lawyer, because they asked me, how will you know at the 20 to 24 weeks if they would have got a sex determination? The question was very simple, what to answer. Hence, this last note saved me telling that I have considered her condition at that time, and hence I have given the MTP Act and rules. But the question comes, if she has 3 to 4 female child, whether it is female feticide, you have encouraged. So while giving a second trimester abortion, and that too between 20 to 24 weeks, please be careful, consider her condition, consider her history, and then consider giving the MTPs. Form 2, that is a monthly reporting form which has to be sent to the DHO. it is like how many cases we have terminated between 9 weeks, 12 weeks, between 12 to 20 weeks, and what was the religion, what was the contraception accepted by her, what were the reasons you are given, that is, what were the indications or what were the categories, and yes, if you have done beyond 24 weeks, what was the malformation. This is the admission register which has to be maintained, telling the date, the name of the patient, age of the person, duration of the pregnancy, what was the reason. I need not write the reason completely. A, B, C, D, what was the indication, those has to be written. Date of termination, date of discharge, and who was the person who has given the opinion and who was the person who has done the procedure. So documentation for other types of abortions, like for example, if it is a spontaneous, inevitable, incomplete, a simple register which is called as an evacuation register, where the documentations like consent form 1 and all those things are not necessary. Yes, you may maintain one of the register called as an evacuation register, and high risk consent can be taken. The sister or the brother of the MTP Act, what we take, the PCPNDT Act, I have to utter a few words about this because MTP Act doesn't get fulfilled without the word called as PCPNDT. It has to be considered because MTP Act runs hand in hand with the PCPNDT Act. We have to improve the sex ratio, check the female feticide and decline in the sex ratio, and improve the sex ratio. So to summarize my part, only the thing categories have to be very clear. Termination is legal up to 20 weeks. Yes, it is an indication considering the categories. Consent of the women more than 18 years is required. If they're less than 18 years, then we have to consider the guardian. Sites, private sites need to get an approval from the district level committee. There are different sites for training and all those things, hence it can be taken. Documentation of the MTP procedures, as I said, you consent form, Form 1, Form E, Form 2, Form 3, Form D. MTP Act and PCP entity, two separate legislation, but considering together. And this will be the end of my topic, but not the end of the discussion, because MTP Act and rules will never be clear, and everyone has got one or the other experience in their setup. Any questions regarding the MTP Act and rules? You can. Thank you.
Thank you, Dr. Pooja. I would request the chairpersons to
Requesting
put in a few
Annapurna
words.
Madam to
Yeah.
please give the concluding remarks, ma'am.
Thank you, Pooja, for enlightening everyone about the MTP Act and how to gain the permission for doing MTPs. One more thing is whether renewal of this thing permission is required.
No, madam. Actually, they are considering e-Kalyani to be started, but there is a little bit glitch going on. Hence, we have to wait for a little bit thing. And once e-Kalyani starts, every hospital has to enroll through the e-Kalyani.
Okay. Thank you. It was a good presentation.
Thank you, ma'am.
Thank you, Dr. Pooja. Thank you, chairpersons, for the excellent deliberation. I think that was so. We have yet another topic on the legality of the POX Act. So I invite the chairpersons for the same. Could we have the session 3? So the chairpersons are Dr. Rupa Arvind, Dr. Dr. Rupa Arvind. She is Associate Professor, Department of Obs Gynae, KMCRI, Hubballi, as well as a fellowship in reproductive medicine from RGUHS.
obstetrician and gynecologist with 18 years of experience in clinical practice, academic work in women health, experience in undergraduate and postgraduate medical education, including teaching, mentoring, supervision, and clinical training. She holds a fellowship in reproductive medicine with training in infertility management and assisted reproductive techniques, focused on patient care, medical education, and evidence-based practice in obstetrics, gynae, and reproductive medicines. Various publications as well as in state level as well as national publications. The next chairperson for the session. Hello, could we move on?
Thank you, madam, for the introduction.
Yeah, the next chairperson for the session is Dr. Meena Angadi. She is an experienced and highly skilled obstetrician and gynecologist and fertility specialist with special interest in reproductive medicine and IVF, laparoscopic procedures, experienced in handling complex infertility cases as well as providing advanced reproductive solutions. Passionate about women's health and committed to delivering high quality care. She is from Gulbarga Obs and Gynae Society, Secretary 2025-2026, Director Vanch Test Tube and Laparoscopy Center, Buragi. She's a consultant Obs and Gynae and has overseen various fertility treatment, IVF procedures, and laparoscopic surgeries. Her area of expertise is reproductive medicine and infertility treatment, IVF and ART, laparoscopy and hysteroscopic surgeries, high-risk OBS and maternal care, sonology and ultrasound in OBS and gynae. The third chairperson for this series, could we have the third chairperson? CV, please. Yeah, thank you. Dr. Udeshri Vurkara. She is an associate professor, Department of OBS and Gynae, KLE JGMM Medical College, Hubli. She's the Foxy Secretary, HDU OBS and Gynae Society 2025-26, IMA FPA Dharwad, FMAS. Then she's won the Young Talent Award 2012 at UA Foxy Madurai. Runners-up at national level AICOG quiz competition in Varanasi, faculty in many conferences and publications in many national and international journals. Welcome all esteemed chairpersons to this excellent webinar and requesting Dr. Rupa to please introduce Dr. MC Patel, sir, the speaker for this session.
Good evening, everyone. It's my pleasure to introduce Dr. MC Patel, who is a senior consultant obstetrician and gynecologist and a medico-legal counselor. He is the candidate for Foxy President Election 2026. Sir has been instrumental in obtaining Foxy uniform consents and medico-legal trainer and has been support for the members. He has served as Vice President Foxy, Chairperson Ethics and Medical Legal Committee, Organizing Secretary AICOG, and has been Chairperson for many national international conferences. Sir has been on national boards of PNDT State, Gujarat, PNDT, NIMC, and also National Managing Board, Indian Red Cross. He has provided community services, serving as Honorary Surgeon, Red Cross, I Bank, collected 1,000 plus IPS, and has also provided services in medical camps in northeastern states and also states of Jammu and Kashmir. And Sir has provided services as a president in Lions Club, as a president of AOGS, president of IMA Ahmedabad, and also national president NMO. Sir's vision is safe mother and safe child. Over to you, sir.
Thank you, madam, for kind words. And let me share my screen. Is my screen seen? Full screen? Is it
Yes,
full
sir.
screen?
Yes, yes, sir.
Fine, fine. So before I go to the subject of FOXO, let me congratulate Dr. Rupa madam. She is like Pooja madam. But word of caution, because being a medical legal expert and appearing for doctors in this type of cases, to take consent in Form C is very much mandatory. And if you fail to take consent in invite litigation under Section 313 of IPC or newer, this is Bharatiya Nyaya Sanhita Section 106. So you cannot afford not to take signature in Form C. It is very much must. But at the same time, Form C is a very simple form. I give my permission to terminate my pregnancy. It is not informed consent. So you will go with two consent in case of MTP. One consent to be taken, which is very much mandatory in Form C, and one informed consent, which usually we take in any other surgery or any other procedure. And for that, you have to simply visit Proxy website, and under Proxy Uniform Consent, there are 30 different consents available. And Dr. Dilip Falke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, prepared 30 different consent. And in those 30 different consent, there are two consent: medical termination of pregnancy by medical method and termination of pregnancy by surgical method. So you can download and you can use it. It is available in English, in Kannada, in Marathi. Gujarati version is ready, and Hindi version is also on. So you can download those consent and use in your day-to-day practice. So with this brief comments, Statue of Unity, tallest statue of world, and we are proud of that statue. Warm welcome, wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and all the president and secretary of respective society. And at the same time, I thank you all. You stood with me during my last election, though I lost. I believe in this, and it is very nicely written by Shraddhe, by for some time. A भी सही, वो भी सही. So loss is not the end, but new beginning, and journey to serve Foxy continued with renewed patience. So thank you everybody for everything. And my commitment is still there. Wherever you are, I'll be there. Promise to reach the unreached. So I'll be seeking your blessings for post of President Foxy election year 2026. And it is my humble appeal to all the president and secretary of respective society to nominate my candidature. You will have a communication from Foxy either in last week of April or first week of May, and this time it is nomination. So you have to simply click to that link. You have to give password, and you will see all the names. You have to simply click the name whom you wish to nominate for post of President Foxy. So you have to simply click on Dr. MC Patel. And with this, nomination will be over within less than 1 minute. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because as far as POXO Act is concerned, there are so many challenges and controversies, dilemmas and controversies, and there are so many legal implications as far as our OBGYN routine practice is concerned. And this act enacted in 2012, and it was specially to protect children from offenses of sexual assault, sexual harassment, and pornography, and provide for establishment of special courts for trial of such offenses and for matters concerned therewith or incidental thereto. And this act addresses this area: sexual harassment, sexual assault, aggravated form of sexual assault, penetrative sexual assault, aggravated form of penetrative sexual assault, and using child in a pornographic purpose is also one more area as far as this POXO Act is concerned. Any person below age of 18 years is minor under this POXO Act. And this POXO Act is gender equal. So it addresses both male and female children. And we doctors are first point of reference in confirming that child was abused or child has been abused routinely. And many a time there is no complaint on part of patient. There is no complaint on part of relative also. They come for some other complaint like itching vulva or discharge per vagina. And if it is a case of STD, many a time on retrograde uh, 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 his taking history, we can come to know that she had been a case of sexual assault. So when this type of patients are brought to us, I will be very quick because I do not want to discuss act in much, but routine situations we face in our practice, I am going to discuss in length. So before examining any patient who is brought for with complaint of sexual assault, then we have to take consent. And who can give consent? Because patient is minor, but if she is more than 12 years, even though she is minor, but she is considered mature minor in eye of law, so she can give consent if she is more than 12 years. But if any surgical intervention is required, say for example, she is bleeding and some stitches are required, some foreign body inside, and we have to remove. So in this situation, consent from guardian is required. History is naturally very important part. So whether it was first time or it is repeatedly she is victim of this type of sexual assault, we have to ask for that. History of bath after this incident, history of change of clothes after this incident, and history of whether threat or any weapon used to threat, any injury. So we have to ask all this history, and then we can examine patient, and we have to find all positive findings to come to our conclusion. Collection of evidence naturally, and we have to document all this, whichever question we raise and what was the answer on part of a patient, and collection of undergarments for, and particularly for any stain, blood stain, semen stain, or any other lubricant or so. So we have to collect all those evidences and we have to document it. Of course, we have to treat patient naturally. If she is bleeding or if she has pain, we have to treat patient accordingly. And this is very important part, that is prophylaxis for STD HIV, because we never know, the accused person could be HIV positive and this patient could be victim of HIV also. So not to end up into this difficulty, we have to offer prophylaxis for HIV and STD also. We have to form opinion and we have to report to police station or CWC in this type of situation. Because under section 19, it is very much mandatory to inform either police station, juvenile police station, or regular police station, or CWC. And if you are head of the institution, then under section 20, it is very much important. And if you fail to inform, that under section 21, there is a provision of 6 months of imprisonment and some fine also. And if you are head of the institution, then imprisonment for 1 year and fine is the provision for punishment. So one cannot afford not to inform police or CWC whenever he is dealing with a case of POXO. Expert evidence in court. Whenever you have formed your opinion, you have reported to the police, you may be called in court of law to give your expert opinion. But court is not bound to consider all the only reports to conclude, come to the conclusion or come to the judgment. But court may take another evidences also into consideration, and court has this discretion in this type of situation, keeping in mind other evidences also. So let us discuss few of the situations we face in our day-to-day OBGYN practice. 16 years old girl is brought by her mother with complaint of vulvovaginitis with discharge per vagina. On examination, she was found to be a case of STD, and on further interrogation, she gives history of sexual exposure with her boyfriend. So in this situation, what will you do? naturally we have to treat patient because she brought for treatment. But at the same time, it becomes a case of POXO. We have to inform police. Let us see one more situation. 17 years old girl with her mother visits hospital with 6-week pregnancy for termination of pregnancy. And doctor explained, of course, I will terminate your pregnancy because my center is registered, I am qualified, but I will have to inform police because you are minor. And in this situation, it is all likely that patient and mother refuse for the same and leave hospital without taking any treatment further. What will you do in this situation? Even if patient doesn't take treatment further, but once you came to know that she is less than 18, she is 6 weeks pregnant, it becomes a case of sexual assault under POXO, and we have to inform police. Let us see one more situation. 17-year-old girl come with her boyfriend and she asks for contraceptive advice. See, many a time it may happen. She will tell, we are going to start our active sexual life and we do not want to end up into any unwanted pregnancy. So please advise us for contraceptive measures. What will you do? Because can you advise? Will you advise? Because there are very tricky situation in this type of situation. One side is a moral duty. Because if you do not advise, and if they have decided to go for active sexual life, it may end, they may end up into uh, pregnancy, and ultimately she will be to you only to terminate pregnancy. But on other side, there is a law because under 18 to give consent for coitus is not valid in eye of law. And in this situation, here considering the POXO Act, if we advise, then we are encouraging them to constitute crime. So it becomes a abatement. So there are three conditions. Either you instigate patient, or you help patient, or aids to constitute crime. It's a abatement. And in this situation, when she is less than 18, and if you advise contraceptive measures, then it becomes a case of abatement, and we have to be very careful. Of course, we can guide them not to end up into this type of activity, and we can guide for contraception also, no issue. But we cannot prescribe, because if at all we have prescribed, and if any proof happens, and that is up to police, then it will be very difficult for us to face the situation. So we should be very careful in this type of situation. Let us see one more situation. 18 years 6-month old married girl is brought by her mother with pregnancy of 39 weeks, and she is for LSCS. So she is major, 18 years 6 months. What will you do? Of course, we have to proceed for cesarean section if it is indicated, but at the same time, we have to inform police, because at the time of conception, she was minor, and in this situation, it becomes a case of POXO. So we have to go for cesarean and we have to inform police. So if we have time, we can inform before cesarean section. If it is an acute emergency, we have to deal with cesarean, and before patient leave our premises, we will have to inform police. Let us see one more situation. Patient gives history of 20 years of age, primary, 8 weeks pregnancy, willing for termination of pregnancy. Pregnancy is terminated. This is real happened case in state of Gujarat only, and pregnancy was terminated. Center was registered, person was qualified, so pregnancy was terminated with all due forms, etc. After 1 month, police comes. She was 17 years. It was case of POXO. Why you didn't inform police? So in this type of situation, very important part is who is responsible to determine the age. Court is very clear. Doctor is under obligation to determine the age. So you can ask for ID proof if at all you are in doubt that she seems to be 18 or less than 18, or could be minor. Then you can ask for any ID proof, school leaving certificate, election card, Aadhaar card, driving license, or you can subject her for clinical examination, for dental examination, for radiological examination or investigation, or you can have opinion from forensic medicine department through police whenever you are in doubt about her age. But to determine age is your duty as a examining doctor. One more area, we have to inform police or CWC. Then how to inform? Inform with acknowledgement, because many a time police may go hostile that you never inform, you didn't inform. So you have to inform with acknowledgement. And if police is not ready to give acknowledgement, because you have sent two papers and one is to be given to police and one is to be signed by police and you have to take it back, many time police doesn't give signature. So in this situation you have some other options also. You can dial 100, it is recorded call. And but in this situation, before you give information, you will identify the person whom you are informing the situation. So name, buckle number are given to police station officer in police station, and date and time you have to inform, because dial 100 is a recorded call, and that very person will pass on this information to respective police station of your jurisdiction. So you can very well inform on dial 100. Same way, you can send it by registry ID post, all this information, by mail, by telephone with recording. If you have facility in your mobile as far as recording concerned, you can inform on telephone also, by mobile. And again, same word of caution, just we inform on dial 100, identify the person whom you are informing. Inform higher officer. If lower officer is not complying to give acknowledgement, you can inform higher officer also. And many times higher officer is also not complying the situation. So in this situation, inform CWC, that is Child Welfare Committee. If you inform Child Welfare Committee, member of Child Welfare Committee will inform police, and police will be serious when Child Welfare Committee members come into picture. Let us see one more situation. Can a doctor refuse to examine a victim of sexual assault who came to hospital for treatment, citing that it is a MLC case and require a police requisition or magistrate order? No, this type of order is not required, and under section 27 of POXO, no need of any police requisition. Under rule 5 of POXO Act, no need of magistrate order, and doctors should examine and do needful treatment and then inform police whenever this type of patients are brought to us or she comes to us. And rape cases, as a medical legal emergency, one has to take. It was in judgment by Supreme Court in case of Karnataka versus Munjana, which was given in 2000. So patient has right to have a opinion and to have a treatment in this type of situation. So voluntary reporting to a hospital or doctor is a legal right of victim of sexual assault person. Let us see one more situation. 17 years old girl visits a private hospital with history of sexual assault. Doctor asks her to go to government hospital as it is MLC case and has to be examined by government doctor only. So it is not like that. It is mandatory that victim of sexual assault has to be examined either at government hospital or at private hospital. So it is not at all compulsory that this type of patient can only be dealt at government hospital. So we have to examine patient, we have to form opinion, we have to treat that very patient, and it is free of cost. In this type of emergency, whenever patient is brought to us, we have to examine that very patient, treat that very patient free of cost. Let us see one more situation. Is it necessary for female doctor only to examine sexual violence victim? So under this CRPC 53 section 2, it mandates that if arrested person is a woman, her medical examination must be conducted by or under supervision of female doctor. So with this CRPC provision, many a time it is interpreted that only and only female doctor can examine the patient, but actually it is not like that. Of course, whenever they are available, it is always to be preferred that female doctor can examine and should examine. But many times, say for example, female doctor is not available and patient is brought and patient is heavily bleeding. Can you wait for female doctor to come? Or if male doctor is on duty, can examine and can deal with the subject accordingly? Of course, one can deal with the situation because under section 164A of CRPC, in that it is very specifically mentioned that medical examination of a rape victim, it mandates that victim be sent to registered medical practitioner for examination within 24 hours of complaint. So here registered medical practitioner is mentioned. Nowhere it is mentioned that female registered medical practitioner. So under CRPC section 164A, any doctor who is registered medical practitioner under Medical Council of India and now NMC, they can examine patient, they can treat patient in this type of situation. Let us see one more situation. 16-year-old girl, victim of sexual assault, was brought to hospital for treatment. Mother insists on you to conduct medical examination, but victim doesn't want examination. What will you do? Here in this case, patient is 16 years. So she is more than 12 years. She can give consent for examination. She can deny also. If she is not ready for examination, then we cannot force. Sorry, what happened?
सर आपका वापस फर्स्ट स्लाइड आ गया सर.
No, I am coming. Something went wrong. I think we were here. Is it full screen?
Yes,
Hello?
sir.
Yes.
Yes, sir.
So 16-year-old victim of sexual assault was brought to hospital and patient was not willing to get examined and mother was insisting. So here she is 16, more than 12 years. She can decide whether to be examined or not. But at the same time, if she is not ready for examination, you can explain what is the importance of examination and why she should be examined. So if she gives consent, it's fine. If she doesn't give consent, you cannot force for examination, even if her mother is willing or she is insisting you to examine her. You cannot examine that very victim because she is more than 12 years. One more situation. 17-year-old girl had eloped with her boyfriend and became pregnant with 16 weeks gestation and requested for termination of pregnancy. She is not willing to reveal her boyfriend's name, requesting not to inform police. What will you do in this situation? Willingness on part of patient or relative is not required whenever it is a case of POXO. We have to inform police. We are under obligation to inform police. It is very much mandatory. So we have to inform police. In this situation, as far as termination of pregnancy is concerned, she was minor, she cannot give consent. So guardian should give consent. In this condition, her father was not ready to give consent. What should doctor do in this situation? Her mother can give consent, but when father has refused, then mother usually in this type of situation may not be ready to give consent in this type of situation. So any person who is more than 18 years, that is major and mentally sound, can give consent as a guardian on her behalf as far as termination of pregnancy is concerned. In institution, head of the unit, head of the department, superintendent can also give consent in this type of situation. In this particular case, this person from CWC were contacted and person of CWC were ready to give consent in this particular case. So when person of CWC was ready to give consent, Now father of patient was ready to give consent. So MTP was done. Now father is insisting for product of conception to be sent for further investigation, but patient was not ready to send product of conception for DNA testing or any further investigation to police. What doctor should do? It is very tricky situation. Patient is not willing to send sample and father is insisting. In this situation again, patient is more than 12 years. She can take decision for examination and for this product of conception to be sent for further investigation. If she is not ready to get this product of conception to be examined for further investigation, one cannot force. But once we have informed police, our job is over. Now case is in hand of police and police will try to explain everything to the patient and try to convince patient for examining sending this sample for further testing. So in this situation, our role is to inform police. That's all other part will be taken care by police. So in this situation, it will happen, and father was insisting, patient was not ready to get that product of conception to be examined because she was not willing to reveal any offense against her boyfriend, and that is why she was not willing to send that product of conception to police. So in this situation, what if gestational is more than 24 weeks? Who's concerned for it? So very nicely covered by Madam as far as MTP Act was concerned. So in this situation, when it is a more than 24 weeks, and if it is a case of POXO, or that is sexual assault, but we have to go for opinion from medical board. But medical board has a limitations. If pregnancy is very normal, medical board has no power to opine in this situation, because if at all fetus has congenital fetal anomaly which are incompatible with life of fetus, in this condition only medical board can opine when pregnancy is more than 24 weeks. And in this situation, even if she is a rape victim or sexual assault victim and pregnancy is very normal, medical board cannot opine, and in this situation one has to go to Honorable High Court seeking writ petition for termination of pregnancy. So one more situation, let us see. 15 years old girl, sexual assault victim, approach government hospital for termination of pregnancy. Mother requested doctor not to inform police and settle matter between them. Something going wrong. Doctor asked them to come to private clinic in evening hours so that he could avoid mandatory reporting and maintain confidentiality. So, sorry, something going wrong. Yes. Is this doctor right in this type of situation? No. So, if patient
Please mute others. Tech support, please mute others.
oh, please mute all others. So mandatory reporting applies to all the hospital, both private and government, and even patient takes treatment further with you in that very hospital, it doesn't matter. But once you come to know that patient is minor and patient is victim of sexual assault under POXO Act, then one has to inform police.
Dr. Rita, please mute yourself.
So to conclude with all this situation, carry home message is, when minor is brought for examination and treatment for complaint about sexual abuse, responsibility of medical professional being an expert increases manifold. Responsible medical professional is under obligation to report appropriate authority about any child sexual abuse he comes to know during his professional medical duty. He has not only to examine and treat, He has to form opinion whether sexual abuse has happened. He is very important person to be helpful as an expert witness to prove crime of child sexual abuse. So comply with the law of land and comply with the provisions of POCSO Act. Be vigilant in your practice. Otherwise, be ready to face this type of situation in your practice. This gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So take medical legal advice from point one in this type of situation whenever you are in a little doubt. So to conclude, if you want to sleep like this, take tender care of your patient, comply with provisions of POCSO Act, pray Almighty God before going to sleep, and keep my visiting card below your pillow, because I am always there to assist you in any odd medical legal situation. So all the best. God bless you. Have a litigation-free medical practice with regards. And to conclude with my appeal, please endorse my candidature for post of President Foxy election year 2026. Salute to all the President and Secretary of respective society and all the faculties and all the delegates. Thank you very much. Please do not assume. Please ask, if at all, any query, any questions, if time and chairpersons permit. Thank you very much.
Thank you, sir. As usual, an excellent deliberation. I would request the chairpersons to speak a few words before we go on to the next session. Chairpersons?
Thank you, sir, for that very informative and elaborative talk on an important and sensitive topic, sir. And thanks for your offer of always being helpful in any medical legal issues. Thank you, sir.
Thank you. Welcome.
So thank you very much, sir. First of all, for making me part of this program. Excellent as usual, sir. Very relevant clinical situations. So many dilemmas will be there in spite of hearing so many webinars or clinical situations are very dynamic. They keep changing. So thank you very much, sir. Thank you very much.
Yes, ma'am. Welcome.
Thank you.
Okay, any other chairperson to have concluding remarks, or we can switch
Respected
over to next session?
chairperson.
Okay. Okay, we can switch over to further next session.
Thank you, sir. We will now move on to the panel discussion. We have a panel discussion on case-based discussions on infertility to be moderated by Dr. Bhagyashree Patil and Dr. Shavis. The experts for the session are Dr. Ravikant, sir, Dr. B.R. Barkol, sir, Dr. Meenakshi Devarmani, ma'am, and Dr. Rashmi Nayak, ma'am. Dr. Bhagyashree is an assistant professor at MRMC Kalburgi. She has various achievements and recognitions to her credit. She is a director of Kadali Shri Hospital. Welcome, ma'am. Next, we have with us Dr. Shavis Faizi. Dr. Shavis is a senior consultant at Nova IVF Fertility at Mangalore. She has a fellowship in reproductive medicine from Kraft Hospital at Kerala. And she's received the first prize for the best paper at the World Congress on Dilemmas in OBGY at Nagpur. Welcome, Dr. Shavis. We have four very eminent experts with us. Firstly, we have Ravikant sir. Dr. Ravikant is the professor in the Department of OBGY at KVG Medical College and Hospital at Sulia. Also the treasurer of KIAGE between 25 to 26 and is the president of the Mangalore OBGY Society. Welcome, sir. Then we have Dr. B.R. Barkol, sir. Sir is the past president of Hubli Dharwad Obsgynae Society. And also, he's also served in the Indian Air Force for over 24 years in various capacities. Welcome, sir. Next, we have with us Dr. Meenakshi Devaramani, ma'am. Dr. Meenakshi is a senior consultant at practicing at Kalburgi. She is also the professor and head of department in Obsgynae at MRMC at Kalburgi. Welcome, ma'am. Next, we have with us Dr. Rashmi Nayak. Dr. Rashmi Nayak is one of the senior IVF specialists practicing at Mangalore, and she is attached to Baby 9 Fertility Center as the clinical director and lead. Welcome, ma'am. We have 8 very eminent panelists with us today for carrying on with the discussion. Firstly, we have Dr. Madhura Banale. Dr. Madhura is assistant professor at GIMS and ESIC Medical College at Kalburgi. Then we have Dr. Shilpa Hugi, ma'am. She is a consultant fertility specialist at Kalburgi. Then we have with us Dr. Sujay Heranjal. Dr. Sujay is the director at Heranjal's IVF at Shirur Hospital at Bagalkot. Next, we have with us Dr. Geeta Bharat, ma'am. She is a senior IVF consultant practicing at Dharwad. Next, we have with us Dr. Vidya Honawal Khoche, ma'am. Ma'am is an infertility consultant at Spandan Hospital at Janani Fertility Center at Hubli. Next, we have with us Dr. Dipti J, ma'am. Ma'am is a fertility specialist at MD Ma Fertility Center at Yelahanka. Then we have with us Dr. Geeta Dopa, ma'am. Ma'am is a very senior IVF specialist at Mangalore. Last but not the least, we have Dr. Nishtha, ma'am. She is the clinical director at Jiva Fertility Center at Dharwad. Over to you, Dr. Bhagyashri and Dr. Shavis. Looking forward to an excellent panel discussion.
Good evening, everyone. I think Bhagyashri ma'am has the slides, so we can start sharing the slides.
Yeah. Slide sharing. Yeah. Can you all see now? Full screen. Okay. Is it all?
Yeah, we can make it to full screen. Yeah. Yes, ma'am.
Yeah. It's there now. It's there now. Am I audible? Yeah. Thank you, ma'am. Thank you, Dr. MC Patel, sir. Thank you, Hiremat, sir. And to all the respected teachers, all the chairpersons, experts of the today's panel. Coming to the panel discussion, what we are seeing in today's day-to-day scenarios is nowadays what we have read is 10 to 15% is the incidence of the infertility. But when you start practicing, you have seen so many increasing trend in infertile patients. When we sit and see in our OPD, the number is increasing. Can be because of the change in the environment, can be because of the change in the lifestyle, or most of the times we blame it on the increasing age of the couple. This can be the one of the reason. Keeping whatever may be the thing when it comes to the clinical practice, with the introduction of AI into so many fields, the AI has also been introduced into our infertility. Can we just make an AI decide what is the management? Will that be sufficient, or the empathy what is being given by doctors will be taken the first footstep in the management? That we have to decide. For all these things, we will require so many clinical expertise, and we also have to have the following things in our day-to-day practice. The objective of today's panel is to have a proper systematic analysis of the infertile patients, and it has to be individualized for age, etiology, and duration of the condition. And depending on the condition, we might have to upgrade or downgrade the treatment. All these things have to be more sensitized with respect to the ethical and the psychosocial things. We keeping all these things in mind, we will be going ahead with the case discussion. The first case, we will be taking two panelists for the case discussions, keeping webinar in mind. And I want to thank all my dear panelists for accepting, even in spite of their busy clinical practice, they have just accepted with my one call. Thank you all the panelists. The first case to Dr. Madhura and Dr. Shilpa. The case is, here is a patient of 32-year-old, and she comes to our to the clinical infertility OPD with the infertility of 3 years and regular menstrual cycles. She has normal ovulation, normal pelvic ultrasound. She has normal HSG, and semen analysis is also normal. BMI being normal, with history of no PID, endometriosis, and surgery. keeping all this history, Dr. Madhura,
Yes,
what is
ma'am.
the diagnosis and how will you come to the diagnosis?
Looking at the history, ma'am, the basic workup is already been done. So having the basic workup being normal, and she's already married for 3 years and not conceived, so the diagnosis is an unexplained. It comes into the category of an unexplained infertility. So next, what could be the other potential causes? So the basic workup where the ovulation is normal, the tubal status is normal, seminal analysis is normal. But I think the other thing which we need to look up is there can be a sperm or an oocyte dysfunction which cannot be seen in the basic workup, or there can be something with the fertilization failure, or something to do with an endometrial receptivity. We need to look for if there is any mild endometriosis. There can be an immunological factors, some genetic causes. There can be, these are the other issues we need to look into, which we cannot know with the basic workup.
Exactly, exactly. In spite of doing all the basic investigations, even when they are normal, there are so many other hidden causes for unexplained infertility. These are some evidence-based things which will explain us. ESHRE in 2020 has defined unexplained infertility, or whatever you have told already been explained into the category. Can you once again tell, Madhura?
Sorry, ma'am?
Can you just tell the causes of unexplained infertility?
The causes here could be any subtle ovarian or an sperm dysfunction, or mild endometriosis, fertilization failure, implantation failure, or immunological factor, genetic factors, and these can be some of the causes for an unexplained infertility.
Okay. Next question to Dr. Shilpa. How would you counsel this couple regarding their treatment options?
First of all, we have to tell them that the basic needs for fertility are normal. So there are good chances of pregnancy in them. And further, they can try with an expectant management for some cycles. And then if still they are not conceiving, then you can give an option of IUI depending on the female's age. And further, if they are very eager, then you can, and the female's age is more than 35 years, then you can provide an option of IVF also.
Exactly.
But you have to counsel them that everything being normal, there could be certain subtle factors that can affect their fertility, that can be opened up only after further investigating them.
Not only investigation, sometimes treatment also will hint at so many other hidden causes. Yeah, when it comes to the expectant management, ESHRE in ASRM 2019 has given the guidelines. The age comes first here. We have to keep the woman age in mind only when the woman is less than 35 years, or when you do her day 2 scan, when you find there are a good number of AFC and all, when there are no explained causes of infertility, then only you can go ahead with the things whatever being told. Dr. Madhura, what are the benefits and risks of IUI versus IVF?
Here, when it comes to the IUI, for this couple, we would be offering it. But then asking for a benefits and the risk, IUI is definitely near to natural kind of a conception we can consider. So less invasive, no cost benefit is there. And the chances of multiple pregnancy is also mild to moderate. The cost, expenses, financial burden is low when we consider IUI. When we consider the IVF, the success rate is definitely higher success rate, but it comes with an added financial burden, invasive, and then the chances of multiple gestation, OHSS. These are the added risk factors which comes within IVF.
Yeah, exactly. Exactly. Well said. Dr. Shilpa, how would you determine the best course of treatment for this couple?
Best course of treatment would be determined depending on the age of the woman. If she is less than 35 years, then you can consider, and less than 2 years of married life, then you can consider an expectant management or an ovulation induction cycle, just to increase the number of eggs she is being released and the chances of pregnancy. Then after some 3 to 4 or 6 cycles, maximum 6 cycles of ovulation induction and timed intercourse, you can offer an IUI with gonadotrophins. And then after 3 cycles or 3 to 4 cycles of IUI, then next step would be an IVF. If she is more than 35 years, then not to waste time. Depending on their financial things, you can directly go for an active management like an IUI and followed by IVF.
Yeah, definitely. We all know delaying treatment by just 6 months can change the whole scenario and outcome of that patient. Dr. Madhura, what are the chances of success with IUI versus IVF?
It depends on the how are we stimulating the IUI. IUI with the gonadotropins, anywhere the success rate will be 15 to 20%, but the cumulative pregnancy rate we need to look. So the cumulative pregnancy rate with each IUI, it increases to 25 to 30% also. When it comes to IVF, it is somewhere between 40 to 50%. And again, the cumulative pregnancy rate will be around 60 to 65% when it comes to IVF.
Yeah, yeah. And always when stimulated the cases, the success rate is better when you compare with the IUI of natural cycle that do have an evidence. So this is what the evidence also is telling. IVF has its role whenever there is 1 or 2 cycles in more than 35 years of age, and around 3 to 4 cycles are younger age patients with all the parameters being normal. In spite of that, those many numbers of IUI, when you are not getting any success, we have to go ahead with the IVF. So, Dr. Shilpa, how would you manage the emotional and psychological impact of such patients?
Ma'am, first we have to reassure that the major defects are not there in them, like the semen parameters or the tubal defects or a uterine defect. So other things we can evaluate further for other subtle things like endometriosis and all. And then there is a good chance of success in such patients. So we have to emotionally, we have to involve a psychologist to counsel them, and proper counseling could bring positive hormonal changes within them, and they may get conceived spontaneously also.
Yeah. Yeah, that's what the problem with unexplained infertility is. Every cycle you'll have to sit and explain every time, because they will be having the reports which are telling everything is normal. But every cycle, when it starts with TI cycles, then also you have to counsel them. Converting them to IUI becomes really a headache. And once the IUI starts failing, the counseling will take its course. So they need regular follow-up, they need regular counseling, and every time it has to be explained to them. Well said, Dr. Shilpa. And what are the potential next steps of IUI or IVF if it is not successful?
Now, if the going ahead in the next step, I think we need to reevaluate them. We need to look for the other parameters, like we need to know for her AMH or the AFC level, the sperm DNA fragmentation. And then if the IUIs are already been done, we need to explain them that they need to go ahead with the treatment. She's already 32 years old. So the option of an IVF needs to be given, or we need to modify our treatment. We need to look back what we have given, how she has responded, what was the endometrial thickness. Can we modify in the treatment? That can be done. We can do the ICSI, and PGTA option can be given. If the repeated IVFs are failure, then comes the advanced option of an donor oocyte or a donor embryo. And the other options of we shouldn't neglect this. We have to give an option of adoption and surrogacy if everything fails.
Yeah, exactly. IVF itself is a diagnosis sometimes. Okay. Gamete factors will come when the embryo transformation will not be happening, proper embryos are not formed, and implantation is definitely still unexplored. Even in spite of doing ERA, sometimes the patients they failed. So all these things will come into picture when the advanced treatment will start in unexplained infertile patients. So how would you counsel this couple regarding the potential of multiple pregnancies? Okay, whenever they are going for ART and all, multiple pregnancies will be there. How are you going to take them forward?
We have to tell the rates of multiple pregnancy in stimulated patients for going for IUI as well as IVF. Uh, there is a chance of single embryo transfer in IVF, provided the embryo quality is very good. Otherwise, there is the risk of twins, or usually twins in IUI as well as IVF. We have to counsel them, and for the risk associated with multiple pregnancy like premature labor, PIH, and preterm birth, everything. We need to counsel them.
Yeah. Yes. Infertility, unexplained infertility, ending up with having twins and getting aborted at around 20 weeks. It really takes a lot of headache. And for the patients also, it becomes very difficult to counsel. They might have spent so much time, so much money, and their patients, their health, everything they will have given. But if ending up like this with multiple pregnancy, they will definitely ask so many questions. So they have to be informed properly. Counseling, every step, counseling is very, very important. There where the empathy, everything will come into picture. Now, coming to second case, Dr. Shavish, would you like to take over?
Good evening, ma'am. Good evening, everyone. Very happy to be here to interact with the other fellow IVF specialists. So let's take the second case. We will direct this case to Dr. Sujay and Dr. Geeta Bharat. This is a 35-year-old male who's married for 4 years, and semen analysis shows a count of 8 million per ml. Motility is around 20%. Normal morphology is around 2%. The wife's evaluation is normal. There's no history of mumps or orchitis in the childhood or in the early adolescence. He's a smoker, and his BMI is 28. Next slide. So let's talk about the Dr. Geeta. What are the potential causes of? So this is basically very obviously a case of male factor infertility. So in our OPD, what are the potential causes that we look at? We see for male factor infertility. Dr. Geeta.
Yeah. Good evening, everyone. Thank you for giving me this opportunity of being a panelist in this panel discussion. As we see in this case, it is a severe oligoasthenoteratospermia, whereas count is 8 million and motility is only 20%, and morphology is less than 4%, that is 2%. So it's obviously a case of severe oligoasthenoteratospermia. Now, usually, we most of the time, even after investigations, we don't find a particular cause, but most common causes we can find out are the infection, varicocele, and sometimes genetic causes like Klinefelter syndrome, Y chromosome microdeletion, and sometimes there may be an obstruction, and many of the times it is unknown, that is lifestyle like smoking, obesity, or excessive alcohol. These factors can influence the count and morphology.
So when we talk about decreased sperm counts, when the counts are less than 5 million, we call it as severe oligoasthenoteratospermia. But within 5 to 10 million, we usually consider it as OATS, which is oligoasthenoteratospermia. Dr. Sujay, how would you evaluate and manage this patient semen analysis? So we all know semen analysis is the most basic and easiest investigation to be done. But of course, there are certain, certain instructions that we have to also give the patient regarding the abstinence and everything. So could you elaborate on this, Dr. Sujay?
I think the amount of information you've given me, ma'am, the duration of infertility is 4 years, and he's 32-year-old, and he has certain deranged semen parameters and lifestyle changes, like he has little overweight situation and little bit of smoking history. Other than that, I think we need to take a good clear history, which is very important. Other than that, we need to make a point that we need to examine the patient. Me being a male gynecologist, I make it a point that I examine. It's not possible for everybody, but it is very important in male infertility that either we get them evaluated and examined by at least an andrologist who's not available, or a surgeon, or any other person who's in the hospital. So I think a little bit of surgical history we need to take, a little bit of environmental history, where he's working, exposure, toxins, and all that. Surgical history like hernia, orchidopexies, and a little bit of sexual history, any sexual dysfunction, erectile dysfunction, ejaculatory problems, any drug history. Obviously, modified lifestyle, you have already mentioned that he's a known smoker and he's already a little bit to the overweight side. And
So also, this is many times the questions, the patients themselves will have questions in their mind. Like, so when you elicit a history of whether they are working in a chemical factory exposed to pesticides, that also helps in counseling, because then you can give them a reason as to maybe this might be the reason what is contributing to your infertility. So again, eliciting that history as a gynecologist or a fertility specialist is very important, because it helps you connect, and the patient also has more trust in what we are saying. Right.
Yes.
Next slide, please. So in the physical examination, can you elaborate?
Yeah, physical examination, I think we need to see for his secondary sexual characters, and just by looking at his external genitalia, just by measuring his testicular size, most of the information is derived majority of the times. And other than that, look for varicoceles, look for any presence of or absence of vas deferens, epididymis. This is, I think, basic examination of most of us can do. And I think other than that, semen analysis,
yeah, can you
we
just
need to do.
specify the practical things that we tell a patient before they are going for collection for a semen analysis? What we as clinicians should tell them?
That's what we need to at least have abstinence. We need to make sure that he's at least having 2 to 3 days of minimum abstinence. Other than that, we need to give him a wide open jar so that he has to ejaculate properly, so that he doesn't spill the first part of the semen, so that the major part of the semen sperms are in the first part, so that he need to collect it properly. And other than that, I usually prefer seeing the total motile sperm count in evaluating the severity of a male factor, because sometimes the WHO 6th edition gives us a criteria. It becomes difficult for us to evaluate the severity of the male factor infertility, and also the modality of treatment is ideal, because if you see the total motile sperm count, the cutoff is more than 20 is normal, and 5 to 20 millions is mild to moderate infertility, and less than 5 millions is severe. So our patient here falls in the category of less than 5, or if you consider his volume is 1 ml, probably we are looking at total motile sperm count of 1.6 million, that is severe. And he falls in the category of IVF ICSI. So majority of the times we might end up doing a lot of IUIs for this patient and end up failing a lot of times. So I think more than just looking at the semen parameters, I think total motile sperm count helps us in a long way in counseling the patient as well as deciding the modality of treatment. Because 5 to 20 is an ideal cutoff for patients to undergo IUI.
IUI.
Yeah.
For Dr. Geeta, what are the benefits and risks for ICSI in IVF for this patient?
Okay, with this lower count and motility and morphology, of course, IVF is not a choice because it will result in low fertility rate and low success rate indirectly. And probably ICSI is the treatment of choice. It is best for severe oligoastheroteratozoospermia, and it overcomes the defects. So the embryologist selects the best sperm possibly available, and of course, it results in high fertilization rate. That is the advantage. Of course, risk is very meager, and probably a slightly increased risk of transmitting genetic disorders or cost. It can reduce the cost to some extent when we prefer IVF over ICSI. But this is not the case for IVF at all. We have to go for ICSI only in this case.
Ma'am, the indications for ICSI, could you just specify?
Indications, of course, severe oligoastheroteratozoospermia and previous fertilization. If the count is normal and we have gone for IVF and it has failed, and even in case of sometimes failed count is normal and previous fertilization failure, we can surgically extract the semen from the epididymis. That is supposed to result in better fertilization rate rather than selecting from the semen sample. And whenever there is high DNA fragmentation, that time also we can prefer to extract from the epididymis and go for ICSI.
Perfect. So the ASRM recommendation is that ICSI is the treatment of choice for moderate to severe male factor infertility. Also, we need to know that if you're going for a non-male factor treatment, it is better to go for IVF, like a tubal factor or some other female factor. Okay, so again, advantages are it bypasses the spermatozoa. We've already discussed this. We'll go to Dr. Sujay. How would you counsel this patient regarding lifestyle modifications, very important, and the medical treatment options?
There has been clear evidence that lifestyle modification, optimizing the lifestyle changes has clearly shown to improve outcomes in terms of pregnancy as well as semen outcome parameters. So this patient is already a little to the overweight side and also a smoker. So probably we should be advising him to stop smoking and probably do some exercise so that he gets his BMI down lower to less than 25. And other than that, rather than just prescribing antioxidants, it is always make sure that we advise our patients to optimize lifestyle, because a combination of lifestyle modifications and the antioxidant use goes a long way rather than just prescribing antioxidants. So other than that, I think if there are some causes, specific causes like any hormonal issues, hypopituitary hypogonadism, I think there is a role of gonadotropins. If there is specific infections, we can treat them. If there is specific some kind of varicocele, probably we can think of repair. And on a clinical, as a practice, I think we can think of using antioxidants for the time of 3 months probably, and not more than that.
Yes. Dr. Geeta ma'am, what are the potential benefits and risks of surgical sperm retrieval for this patient?
Since the count is 8 million and 20% mortality, I don't think surgical retrieval in this case is necessary.
Right.
Surgical retrieval can be necessary when the patient has azoospermia. Surgical extraction may be in the form of PESA, TISA or micro-TISA. Sometimes we have failed fertilization with a semen sample, then we go for a surgical extraction from the epididymis. That is one of the indication wherein even if we get sperms in the semen, we go for a surgical extraction. Probably this patient doesn't require surgical extraction.
Yes.
Probably if we have done a DNA fragmentation index and that is quite high, then again you can think of going for epididymal sperm extraction.
Dr. Sujay, how would you manage? So main thing we know that it's a little difficult for males to accept that they might be the cause for infertility. So how do you manage the psychological and emotional aspect of this?
It's always good counseling and reassurance, and I think we need to make them sit together, explain what is the main issue here, and explain to them that there is possibilities and good ART treatments available that they can have a good outcome. I think end of the day, I think good counseling and reassurance is the way forward.
So as per the new ART rules and regulations, we all the IVF centers should have a psychological counselor also. So it's always better to connect them to an expert who can also kind of make sure that there are no marital issues when they go back home and the blame starts between them. Dr. Geeta, what are the potential next steps if ICSI does not work out, is not successful?
Okay, then of course we have to again in detail we have to evaluate the couple, how are the oocyte quality and how are the sperms and whether DNA fragmentation index or any karyotyping is done in a male person. And after all this, if it is normal, again we can repeat the cycle with the altered stimulation protocol and do a surgical extraction and do ICSI again. And of course, donor gametes is the next option. And if that also fails, adoption is of course an option all the time.
Next.
May I add one thing in this?
Yeah, sure, ma'am. Sure, please.
Actually, before going to ICSI, these patients, OAT patients, should undergo genetic evaluation. They
Yes,
have family history of same brothers are having infertility and OATs also. And many patients are getting, if possible, whole exome sequencing, at least karyotyping.
Yes.
Even
Yes, sir.
unexplained infertility also, we should go for genetic analysis before going for any invasive.
We are coming to it, ma'am.
Yes, ma'am. So, Dr. Sujay, last question for you on this question. What about counseling this patient and considering any genetic abnormalities in the offspring?
As madam already mentioned that patients with azoospermia and also severe OATs, I think we need to think of at least getting a karyotype done to rule out certain abnormalities like Klinefelters and also Y chromosomal microdeletions, because there is chances of transferring to the offspring. And especially other thing is in non-obstructive azoospermias, we need to see for the carrier status of CTFR gene mutation, CFT gene mutation, because we need to check the carrier status in the female partner also before we go ahead with any kind of ART procedure in these obstructive azoospermia patients.
Yeah, that's
Coming to third case, I would like to invite Dr. Vidya and Dr. Deepti for this case. Yeah, the case is 30-year-old woman with infertility of 3 years. She has severe dyspareunia, and on ultrasound, there is an endometrium of 4 centimeter. Dr. Deepti, how does endometriosis affect fertility in this patient?
Endometriosis as such, we know, is a chronic inflammatory state. So it distorts the pelvic anatomy. So there'll be impaired uterotubal anatomy. Because of that, the sperm the sperm movement into the uterus also is impaired. There is inflammatory environment. Because of that, there'll be impaired sperm, oocyte, and embryo function. The ovarian reserve will be on the lower side in case of endometriosis because of the toxic the toxic inflammatory state. And there's altered endometrial receptivity because of the progesterone resistance, which is present in case of endometriosis. And along with this, the oocyte quality also will be poor. So because of all these things, endometriosis will affect the fertility and cause infertility in these patients.
Yeah, definitely. So depending upon the stage of the infertility, the effect of the endometriosis, we can divide in mild to moderate. It will be little mild. You can plan the conservative modes. Whereas if the endometriosis is advanced, you will have more severe, like both mechanical and inflammatory effects will be very much more on the structure as well as on the quality of the oocytes. Dr. Vidya, what are the medical and surgical management options of endometriosis in this patient?
If
Dr.
she's
Vidya? Yeah, ma'am. Ma'am, can you be a little closer to the mic, ma'am? Yeah.
If she's having pain symptoms as pain and she's coming to you as for infertility and 4 centimeter endometrioma, I will do a surgical management first and do her tubal and evaluation along with the surgical removal of endometrioma.
Madam, even if the pain is more and the endometrioma size is less than 4 centimeter, you want to go with the surgical management?
Then I can give, if there is no pain component, tubes are patent, then we can give OC pills. But she is coming for infertility. Basically, her problem is infertility. So we should concentrate on infertility. Giving her NSAIDs will be choice, not giving her any OC pills or anything which will be against fertility treatments.
Why? Because both infertility and conservative management, they both can't go hand in hand.
Yes.
So both will take different ways. That's why we'll have to decide which way we have to go ahead. Yeah.
If it is less
Thank you,
than
madam.
4 centimeter, there is no need of surgical management. You can go ahead directly for infertility treatment, explaining her that I cannot give you OC pills or any contraceptives for pain. You can manage with NSAIDs or something for pain relief. Otherwise, if it is 4 centimeter and symptomatic, you better to go for surgical removals and then plan the treatments.
Yeah, definitely. Thank you, madam. Next, Dr. Deepthi, what are the benefits and risks of ART in endometriosis related infertility?
In endometriosis, what I would suggest is, in case there's a chocolate cyst, I would suggest go for a laparoscopic procedure and go for an IVF immediately, the next cycle itself. After the laparoscopic procedure, we'll give them GnRH agonist. The next cycle only, if they go for an IVF, ICSI procedure, it is the best option because I have seen that their ovarian reserve decreases. Even though their AMH is good, the oocyte quality will be poor. And though they're young, the success rate for them in IVF also is a little on the lower rate as compared to patients without endometriosis. So I would suggest IVF is the first option for patients with moderate to severe endometriosis, or even in patients who are above 35 and have endometriosis. I would suggest go directly for IVF.
Exactly. We have to guide them properly. Otherwise, the patients will be open for any kind of treatment. If we don't guide them properly, they will end up in ovarian failure and third-party reproduction and all. So these are all different considerations and different guidelines which are telling that depending on the condition, which mode of treatment will be proper. So ASRM is also recommending avoid repeated surgeries. Do not rely on ERT unnecessarily, and IVF outcomes are accepted. It's definitely better when the patients are at younger age group. And Dr. Vidya, how would you counsel this patient regarding the impact of endometriosis on her fertility?
This patient is 30 years old. And
endometriosis being one different type of a disease, sometimes you'll not have anything to explain in ultrasound or some imaging, but on laparoscopy will have found so many lesions inside. When you start explaining them, first thing is to make them understand the disease itself takes a lot of time.
First, we should tell them what is the endometriosis and what is the meaning of the diagnosis given to them, and how the disease spreads and the chronicity of the disease, and the AMH or antral follicle count may decline with age, and this disease is not getting. We cannot limit the disease spread, so it is better to go forward for any infertility treatment which is fast forward cycle. First for this patient 3 cycles of IUI, and then if she fails, go for ART directly.
Yeah, exactly. We have to make them understand. We should tell them the disease stage, and if delayed, what can be the outcome.
Yes.
Dr. Deepti, what are the potential benefits and risks of surgical management of endometriosis for fertility?
The surgical management of endometriosis is required because, the risks will be obviously the ovarian reserve will decrease further, and there'll be a lot of adhesions. So there could be, chances of bowel injury and, harm to the other organs, because we all know that in deep endometriosis, the bowel is involved, the intestines are involved. So because of that, we have to be very careful with the surgery. And we all know there's a recurrence. So we have to tell the patient for sure that surgery is not the end of it. So it will recur. The recurrence rate is almost 30 to 50%, and it will definitely recur because many patients have this, anxiety that after the surgery, everything is over. So otherwise they feel that the surgery was not enough, or the surgeon didn't do his job properly. So we have to, tell them clearly that there's a recurrence risk, there's a risk of, ovarian damage, and there's a risk of, bowel injury and injury to the other organs, because there'll be a lot of pelvic adhesions. So all these things have to be told to the patient.
For them, for infertility treatment, today is better than tomorrow. That they should understand. They have to be on the faster track.
But
Doctor,
for a surgical management, I think if I am not competent enough, I would like to call an expert
that
person.
generous,
These complications are less in every Dharwad or anywhere in Karnataka, pan India. You get expert surgeons, so please get operated from them, so that one surgery is enough for her future fertility. Because
that
repeating
definitely.
surgeries
Whenever you are doing
loss.
surgery, it has to be justified properly. That's really required, madam.
One
How would you
surgery.
manage, Dr. Vidya?
Yeah.
How would you manage the emotional and psychological impact of endometriosis on them, especially when the patient is very young?
Every visit, if we are planning for fertility management, her pain is not taken care of. She should be
homework
counseled for
EVS
the pain.
homework.
She should be counseled for fast track treatment, adherence to fast track treatments, because time to fertility will be less.
ગુજરાતી આપી તો ક ખ ગ
Stress,
વાળું ક
because the
વાળું
disease name is only
જો
stressful for
દેખ્યું નહીં
them. So all these things should be counseled to the patient with each and every visit, as well as her family members.
Every time you will have to counsel her, especially when the patients are very young. Nowadays, we are seeing even unmarried patients are coming with endometriosis. Counseling them for the fertility and fertility preservation, all these things have to be done properly. Dr. Deepti, what are the potential next steps if medical and surgical management are not successful?
If the medical and surgical management is not successful, they have to be they should opt for IVF ICSI. And if the reserve is very low, and sometimes even if we stimulate them, doing the egg pickup becomes very difficult. If there's if the ovaries are not accessible, and there's too many adhesions and all, in those cases we have to counsel them for donor oocytes. And in certain cases, the endometrium also, the uterus, the endometrium also is not good. So they should be counseled for surrogacy also if required. So if medical and surgical treatment fails, you have to counsel them for the next things, IVF, and in case of low reserve, for donor oocytes, and in case of if surrogacy is required, that also should be counseled.
Yeah. Usually adenomyosis is seen in most of the patients, so that possibility is also very high in them. Yeah, Dr. Vidya, how would you counsel this patient regarding the potential of recurrence of endometriosis after treatment? Yeah, you already answered that question. Yeah.
Recurrence is very common, and as pregnancy gives progesterone, it will reduce the symptoms temporarily. So they should be counseling is done pro pregnancy, that they should get pregnant as early as possible.
Yeah. Yeah, most of the times they take a pause after first treatment, and usually after surgical management, what they think the disease is already done, cured, and they want to take a break and they go on holiday. All those things they'll do, and they'll come back with the recurrence of the disease, or most of the times they'll come back with the endometriomas, which were already drained, or the cystectomy was done. They come back like that. So the patient has to be educated properly about the disease
Before
process.
surgery
It's
only, before
yeah.
surgery only, they should be counseled that this is the first step of treatment, and these are the steps, next steps. Then only the treatment will be completed. Only surgery is only the way to the treatment. It is not a complete cure.
Final treatment. Yes, madam.
I would
Thank you.
suggest do the IVF the very next cycle. Give them
Yes.
GnRH agonist on the, day of the surgery. Do IVF the next cycle.
Exactly. That has to be done. That has to be done. Then only the justice will be done for the surgical management, or else it will be a recurrence. Next case. Thank you both, Dr. Vidya and Dr. Deepti. Thank you joining. Thank you.
So
Dr.
we'll carry
Shabi?
on. Yes, ma'am. We'll carry on with the next case, for which I'd like to invite Dr. Geeta, madam, and Dr. Nishtha. Good evening, ma'am. We'll read out the fourth case, which is the 31-year-old woman who has 2 years of primary infertility, and she presents with regular menstrual cycles. Her husband's semen analysis is normal, and HSG shows bilateral hydrosalpinx. So the ultrasound reveals dilated fluid-filled fallopian tubes. So this is basically a tubal factor for the infertility. So we'll go on to the next slide. So we'll start with Geeta, ma'am. So madam, the potential causes of tubal factor infertility, could you just elaborate, ma'am?
Yes, so tubal factors, mainly it is pelvic inflammatory disease. Most commonly, PID can be caused by sexual route or any copper T insertion, MTPs, or any procedure, surgical procedures, which may lead to infection, leading to the inflammation and infection of the tubes. In Indian setup, genital tuberculosis, we should always keep in mind, because that will be a very important cause. So mainly if you see hydrosalpinx, it will be PID or genital tuberculosis, which we can see. Sometimes it can be there with endometriosis. Endometriosis, many times it won't cause tubal block as such, but distorted tubo-ovarian relationship can be seen most of the times.
Yes. Okay. Next slide.
Coming.
So Dr. Nishtha, how would you evaluate and manage this patient's tubal factor infertility?
Yeah, ma'am. Since she's already come with a case of tubal factor wherein there is evidence of on ultrasound that both the tubes have been filled with free fluid on both the sides. Ultrasound, if it is showing more than 2 to 4 centimeter, I don't have a I would rather prefer and counsel her regarding a diagnostic lab and a proper thorough consent that if the proper ciliary damage is very much evidenced, as in case we see with bilateral hydrosalpinx, a proper thorough consent that a better process along with the diagnostic histolab is tubal delinking. Anyhow, once the tube is damaged, it is damaged permanently. So I am not a person who will go sit and operate and do some manipulation so that the tubes are patent somehow after surgical correction. No, straight away happy person to treat a patient with bilateral tubal block with IVF, provided a thorough consent in explaining the patient regarding tubal delinking in the form of laparoscopy.
So many times these patients have the false hope that with the removing of the block, the tubes will become fine and everything. So that, like you very well explained, this function of the cilia is very important for the transport of the gametes, which we have to tell the patient and counsel properly. Yes. Geeta ma'am, what are the benefits and risks for surgical repair versus ART?
Yeah, so there are different surgical repairs as we are seeing. Proximal block, yes, you can do hysteroscopic tubal recanalization. If there are mild adhesions, laparoscopic adhesiolysis. And if there is mid-tubal block, sometimes you can do end-to-end anastomosis also, that also works. Then distal block, fibroplasty, but usually results are not that good. Severe block, we go for IVF. And definitely hydrosalpinx will go for the salpingectomy. Yes, now surgery. Surgery, when we are going to do, when there is mild to moderate disease, we can go for the surgical management. Like tubal recanalization. It does wonders. Definitely, we have seen so many pregnancies with that. But if there is severe block, definitely surgical management is not going to help us. Either it will result in infertility or definitely an ectopic pregnancy. Then if we see for the result of pregnancy, yes, surgery, definitely you can get 120 to 40% result. But with IVF, the result of pregnancy will be little higher. And then if you see time for pregnancy, we don't know. If you have done surgical repair, we don't know when she is going to conceive. But if you are going for this salpingectomy or tubal clipping and going for IVF, definitely if we take care of this tubal factor, pregnancy can take place at the earliest. So, and also if surgery, if you have done, it is successful, then it is permanent, because if she's a preemie, next time again she can conceive. But if it is IVF, again next time when she wants to conceive, she may have to go for the IVF also. But cost, definitely surgery also is going to cost, but definitely IVF will cost a little more as compared to the surgery. So this is the pros and cons of surgery and IVF treatment.
So the other thing also which I would like to highlight on this point is that whenever we are thinking of any surgical management where we want the patient to try naturally after that, we also have to consider other factors like how is her egg reserve, whether her husband's semen analysis parameters are good, then we can give them the surgical management for something mild and then ask them to try for a given timeline and then see if it's working out for them or not.
And mainly, see, if you're thinking of tuberculosis, definitely our endometrium is gone there. So very difficult for us to get implantation because there will be so much thin endometrium and other implantation problems. So all the other things also we have to see along with the tubal factor.
Any infertility case, we cannot just go as a black and white thing.
Yes.
It has to,
Yes.
entire picture in consideration.
Yes.
Dr. Nishtha, how would you counsel this patient regarding potential benefits and risks? I think ma'am has briefly discussed. So we'll move on to the next slide. I think we'll take the next question with you. This also ma'am has already discussed surgical repair versus ART, ma'am has already discussed. So Dr. Nishtha, what are the potential next steps if treatment is not successful? We can just...
Yeah, next step is since for me, seed and soil theory is utmost important in cases of tubal factor. Once we are very much sure that in this case, isolated only the tubal factor is there, and she should be offered with a proper IVF after her hormonal profile, everything is done. Even if she fails, offering of repeat IVF cycle with slight changes in the stimulation protocol. And if at all PGTA was not done in the previous or baseline first attempt, if the remaining embryos are in the repeat cycle, offer her a PGTA as well. And donor oocyte comes in the list if there is no pregnancy at all. And yes, adoption surrogacy can also follow in future.
Next slide. Dr. Geeta, how would you manage the emotional and psychological impact of tubal factor infertility on this patient?
Yes, definitely, because once it has been labeled that she has a problem, definitely she will have the guilt. In the family also it will come to know, and she'll be so much psychologically disturbed. So husband's factor is normal, but for me, because of the tube, I'm not getting pregnant. So here, very important, we have to be very empathetic and give emotional, psychological support to the patient. And we can counsel her, and definitely we can refer to a fertility counselor who can still take care of her better. And then we should take both the partners together and we should counsel, because whatever has happened in that, her mistake is not there. If any infection is there, tuberculosis is there, it has happened, it is no problem because of her which has happened. So all these things we have to take together, and we have to counsel this couple. And then also we have to counsel them that if you take the treatment properly as per advice, there are very good chances that she can become pregnant and have a healthy baby.
Perfect, ma'am. Next slide, please. Dr. Nishtha, what are the potential benefits and risks of IVF in tubal factor infertility? You just
Yes, the benefits would be ideal. I said I will be a happy person to treat such a patient and tick my fertility success by one more mark, having only isolated tubercular or hydrosalpinx. Excellent prognosis compared to any other factor. And we should always counsel thoroughly, both keeping husband and wife during the counseling process in the chamber, regarding that tubes are only mandatorily required only in TI or IUI conception. However, if they do fail with 3 or 4 attempts of IUI, tubes are the organs wherein we have to bypass, and there is no actual necessity of tubes in case of IVF. So again, higher fertilization rate, and depends on the type of protocol. If she happens to be a normo reserve or a hyper reserve, hyper response patient, OHSS and multiple pregnancy, yes. Since we have offered already a diagnostic lab, and if you have already done a tubal clipping or a tubal delinking in such patients, even then certain cases of ectopic can be expected out of as a risk factor when these patients are subjected for IVF. And procedure related risk very minor. If we are very much thorough in our OPU skills, accidental puncturing of tubes and all are practically ticked out.
Yes. Okay, we'll take the last question with Geeta ma'am. How would you counsel this patient regarding the potential future successful pregnancy?
Yes, here only there is a tubal factor in this case. So we can tell her, yes, definitely if it is only a tubal factor which is there, it has got good prognosis with IVF. Her age is only 31-year-old and we have to see for her ovarian reserve. With good ovarian reserve, she has very good chances of pregnancy. Yes, and regarding the risk, yes, if you do a single embryo transfer, less chances of having multiple pregnancy. And because she has a hydrosalpinx, we have to do clipping of the hydrosalpinx or salpingectomy before the IVF to improve the success. And we can explain her how much is the rate of successful pregnancy, how is the fate of the IVF, what can happen. And in case if it is a mild tubal problems, then definitely tubal cannulation, etc. can also help. So we have to explain her how are we going to treat it and what is the result of this treatment.
Okay, now I want to ask one open question to all the IVF specialists here. Do you do a salpingectomy before ovarian stimulation, or do you do a salpingectomy after you have got the embryo stored in your lab?
I do it before the embryo transfer, that is after the stimulation.
Yeah, it is better.
Yes,
to
I
after
opine.
the
I have the
stimulation.
same opinion. Ideally,
Because
carry out
the blood flow to the ovaries will be impaired to some extent with salpingectomy prior to the ovarian stimulation.
Yes.
So because of that, doing it prior to the embryo transfer is better.
Yes.
Do you believe that having a hydrosalpinx in the adnexa can cause inflammation, which can influence the quality of the eggs?
Yes.
Yes, definitely.
I'll just give one small anecdotal thing. We had done the same thing. We had done an IVF. We had done stored the embryos and everything, but the patient had very poor quality embryos, or I think they were not even viable and all of that. Then we went for the salpingectomy. She had a unilateral hydrosalpinx and she conceived naturally. So definitely we all know the effect of inflammation on the egg quality, and probably even the endometrium also gets evolved. We don't know. So
Yes.
maybe somewhere that also plays a role in the success rates of IVF.
There are enough
Yes.
papers wherein it is said and it is proven that in case of unilateral hydrosalpinx and the quality of oocytes on that particular or ipsilateral ovary, fertilization rate and embryo formation potential rate is absolutely cannot be compared than that with the other tube, which is having a normal or a patent tube. So even the oocyte quality matters in case of unilateral hydrosalpinx during counseling.
Yes, that's true. That's true. That's true. Coming to the last case. Last case. I hope all of them are there.
Yes, ma'am.
Yes, ma'am.
Yeah. So last case is, present scenario. Everybody is getting such patients more often nowadays. The patient age is 38-year-old, primary infertility since 2 years, has regular menstrual cycles, no medical illnesses, semen parameter is normal. She has come to you as primary infertility. So first, Dr. Vidya ma'am, how does the age affect fertility in this patient?
Age will definitely give the poor quality of oocyte, and her reserve will be, quantity of eggs also will be reduced. Means her reserve will be reduced and quality of eggs also will be poor. As well as if she tries for pregnancy at that age, time to pregnancy will be more, abortions will be more. So it is better to go for IVF cycle, see the oocyte quality, if possible PGT, and then do embryo transfer to have a better success rate and fast track pregnancy with her own oocytes.
Yeah, definitely, definitely. This age group, definitely IVF is preferred over the other method of treatment, as we have multiple evidences saying that the quality of oocyte decreases, miscarriage rate increases, the abnormal pregnancies will increase. All these things put together, when we do IVF and PGT, there is definitely having a proper embryo and getting transplanted will increase. What are the chances of benefits and risk of ART in age-related infertility? Dr. Geeta Doppa, ma'am.
Yeah. So benefits and risks of ART. Yes, definitely ART is really helpful because now she's a 38-year-old lady. So definitely it is going to shorten the time of pregnancy. Yes. And then as Vidya ma'am said, IVF PGT, if you do, the less chances of aneuploid embryo transfer, less chances of miscarriages will be there. And in case if it is required, donor eggs will improve the success rate dramatically. Yes. And risks, yes. Sometimes even if you stimulate with higher doses, they don't respond. Then higher cycle cancellation rates because of aneuploid is increased chances of miscarriage. And because of this mental strain, patients increasing age is worrying her, and also financial burden. So all will lead to a pathetic state of this couple.
Yeah. What is your opinion on embryo pooling and going for third party directly, madam?
Yes, we can go for embryo pooling. Depends on the how much is getting this. How many oocytes we are getting. Definitely, embryo pooling is very good. We have to counsel the patient. If she wants third party, we can go for it. Otherwise, we can do embryo pooling and we can try for it. But again, we have to do PGTA. Many times what happens, we get the embryos. But when we do PGTA, we will see all of them are having some aneuploidies and we are not able to do the embryo transfers. So that is the problem in this age group.
Yeah. Exactly. Third party can be told as an option, but we cannot put on them. So if they are very, very keen on having their own genetic material, we'll have to encourage them for all other methods. So what are the...
AFC is very poor and AMH is very poor. Semen parameters are also very poor, and cost is the main factor for them. We should give them option of egg donation also. If one at least one gamete we can correct and get good embryos and give better success rate, if finance is a concern for her.
Yes, madam. Next, one second. The question is not seen properly. There. The third question is, what are the potential next steps for the treatment for this patient? Already we have discussed. Okay, donor or PGT, all these things we have to do. And anyone wants to tell about the PRP to increase ovarian reserve, all these patients? What are your experiences, madam? Out of these questions, I just want to have an open discussion about the
Stem cells.
Stem cells. Yeah.
If
anyone want to share their experience?
Anything stem cells or PRP we do, I think we may increase some quantity, but we cannot increase the improve the quality of oocytes and quality of embryos and pregnancy rate.
Yeah, exactly. We are going to increase patients' expectations to the sky level, also to the expenditures to the sky level. In the end, if at all they are going to end up in failure, the emotional changes also will have fallen to that level. So that will take different.
That this type of treatments are available, and we should give them reality. What is the success rate of this and what is the cost? Because if they will lose interest in fertility only, and so many life issues and marital issues will happen in their family.
True, madam. Then what are the benefits and risks of this treatment, madam?
Which treatment?
Dr. Deepti?
The risks of IVF will be, again, multiple pregnancy. There'll be, risks of, because she's elderly, they'll have risk of diabetes, hypertension. There is preeclampsia and gestational diabetes. They'll have risk of preterm labor, and they could have abortions also. So all these things have to be counseled to the patient. All these, and she may have to undergo. In case PGTA is not done, then she has to undergo invasive procedures also, like amnio, CVS may be required. All these things have to be counseled to the patient prior to, prior to doing the IVF.
Yeah.
Actually,
Now, any
before
ART pregnancy is considered as an high risk pregnancy. Upon that, maternal age is also added here. Definitely, when age is added, other maternal risk factors will have been added. So she will fall under definitely high risk
Another
patient.
thing, another,
yeah, in
another
fact,
thing is after stimulation, the risk of getting zero eggs, no
yeah,
eggs, that
even
has to be
during
considered. That
cancellation
will
during
have to be.
stimulations are very much,
Oh.
and
Yeah,
poor
cancellation.
embryo quality, and no we cannot do embryo transfers. These chances should be
Still,
explained in before to the patients. That means if you do 5 day stimulation and then tell patient that you are having only one or
Yes,
two
yes.
eggs, it is very sad on our part. You should tell them.
Any poor ovarian reserve patient will have to be explained about the cycle cancellation before we start the treatment. Definitely, she will need. Dr. Shilpa, what are the potential benefits and risks of donor egg or embryos?
donor eggs, definitely the chances of success is very high, since the quality of the eggs will be better, and multiple pregnancy rates are more, and though the donor is screened, some unknown factors like the certain genetic factors that may be there, that could be carried away in this pregnancy also, because we may not screen all the donors for all the genetic material. So that could be the thing, and acceptance is one of the thing by the male partner. Though we counsel them, but the acceptance has to be there. There should not be any issues later on in life regarding the donor oocytes.
Actually,
To highlight one
practically,
point here.
practically seeing the donor eggs, we are not getting good donors. We are not getting good egg quality in the donors at all. If even if we are seeing so many follicles, the egg quality is poor, embryo quality is poor. It is a big issue nowadays because these
Though the
donors,
ART bill has come into action, still
yes,
you will
these
not
donors
get
have
proper.
repeated donations, and really counseling the patient for donor and giving success rate of 50 to 70%. It is not at all practical. I have to tell patient that these type of donors we are getting.
Yeah, one point in counseling, what I usually consider is even if she conceives with donor oocytes in this present cycle, however, she's not a case of POF, she may happen to conceive in future spontaneously on her own. In that situation, she should not be, or her couple or her family, whoever is aware that the first pregnancy was through third party, they should not be having any differentiation if she bears a normal child after this IVF with third party.
Yes, yes. During
Exactly.
COVID
This is an
period, COVID,
important point. It has to be
yeah, yeah.
considered.
Even
Yes.
donor semen also many patient conceive
Ma'am,
in
another thing that
COVID
I
period.
want
So many OD cycles conceived naturally.
Ma'am, one more thing, since on Vidya ma'am's comment on the donor quality nowadays, we can also give this thing option to the patient for altruistic donor. Sometimes if they have a younger sister, that way the cost of the treatment also comes down, and they know their sister very well. If the sister and her husband are willing for this, of course, legally,
She
they
has
have.
to come through the ART bank only. She has to
We
be
should
taken
we
to
should
Yeah,
ART.
yeah,
register
but
them. We should register them through the ART. We can
Yes,
register
but we have
those
patients
donors.
with less number of eggs also, but better quality than the
Yes,
the
yes.
donors who come through the bank. So
Yeah, it is
Yes.
better
not
to
Yeah.
have their
very
own donor
commonly done,
registered.
but some do agree to donate to their family.
It still
And,
does exist. Some people do come forward to do that. Yeah.
and one more thing,
Yes.
chances of forming embryos with only 7 oocytes being retrieved is also less. So we don't know how far the donor cycles are also successful nowadays.
Even if
Yeah,
we
7
are having
oocytes.
15 two sides, we are not getting 3 to 4 embryos nowadays.
Third
Good
party
quality
reproduction
embryos.
ART bill, it is big debate. Big debate. Don't know practically how much it is implemented. We all do agree that. So all these things, the next questions are almost similar. We are all talking about the same things, the emotional changes in the patient, how to handle with the anxiety of the time running out, and how to accept the third party babies. All these things, they take lot of counseling into our OPDs. Because of the increasing age of the couple, these cases have become very common in our day-to-day practice. So we all should understand the emotional changes in the patients, what are the time requirement, what are the possible things offered to the patient, and how can be the outcome. So counseling takes lot of major time of our OPDs. So these are some clinical scenarios what we have gotten into today's panel discussion. Thank you everyone for getting participated into our panel discussion and giving your valuable time. I thank each and everyone, Dr. Madhura, Dr. Shilpa, Dr. Vidya ma'am, Dr. Geeta, Dr. Deepthi, and my dear friend, Dr. Nishta. Thank you, everyone. Thank you.
Yes.
Thank you, all the
Thank you.
chairpersons. Thank you, experts. Thank you.
Thank you, ma'am. Thank you.
Thank you, madam.
Over to you. Over to you. I think all of them have already
vanished.
Yes, only 19 are remaining. I think we can also say bye-bye to each other. Thank you.
I
Thank you,
thank
all
you.
of you. Bye. Bye.
Dr. Meenakshi Devarmani, thank you for the very good panel
Thank you,
discussion.
everyone.
Dr.
Thank you.
Bhagya and Dr. Shaviz and all the panelists. It was a very good analysis.
Ma'am, it would be nice to
Congratulations to
see
all
you.
of
It would be nice to see you.
Ma'am,
Your
please
audio.
come on the screen.
Nishta.
See you, ma'am.
Okay,
Bye.
thank you, everyone.
Thank you.
Thank
Even
you,
I am
sir.
very happy
Thank
to
you,
see
Barkol
all
sir.
my
Thank you, sir.
students.
Thank you.
Thank you, sir. Thank you, Meenakshi ma'am. Thank you for giving your time, ma'am. Thank you, Barkol sir. Thank you for
Thank you,
accepting.
madam. Thank you.
Thank you, sir. Thank you, sir.
So big round of
thank you,
applause
everyone.
for two learned moderators and all the panelists and experts putting their inputs, making this panel very interesting and fruitful. So
Thank you,
thank
Patel
you
sir.
all.
Thank you, sir. Thanks for the
Thank you,
opportunity.
sir.
Namaste.
Thank
Namaste.
you.
Sir.
Yes.
Thank you, sir.
Thank you, sir.
Thank you and good night.
Yes.
Good
Thank
night.
you. Thank you.
Good
Good
night.
night. Yes.
So our special thanks to Corona Remedy. They are supporting us in this series as educational support. So thank you, Nilesh, and all the team.
Thank you, sir. Thank you so much. I'm ending the session, sir.
Oh yes, we